Hello everyone and welcome to this IJB meeting. For those of you who don't know me, my name's Stephen White. I'm a non-executive member of NHS Tayside and chairing for the first time, taken over from the infamous and extremely competent Julie. So hopefully Julie will sit right in front of me and keep me right if I go astray. So thanks for that. I believe we have two new members joining us today, Gemma Reid and Ron McComiskey. I hope I said that correctly. So welcome to you both. And with that, I think we'll move on to the first item on the agenda for any apologies.
Thank you, Convener. We have apologies from Andrew Thompson.
Okay, and any declarations of interest? Oh, sorry, do I need to read out the... See, I've already got it wrong. So anyway, I need to read this out. Welcome to this hybrid meeting of the Integrated Joint Board. I would remind all attendees that this meeting is being recorded and webcast live on the Council's YouTube channel. I have agreed the attendance of some members remotely and would remind all remote attendees to mute their microphones when not speaking. For any members of the public watching, please note that all the public committee reports, including details of specific recommendations, are available on the Council's website. Okay, thank you. So any declarations of interest and statements of transparency? Nope. Excellent, thank you. Okay, so if we move on to item 3A, the minutes of the previous meeting. Any comments, questions?
Yeah, thank you, Chair. Just to pick up in terms of page 7, there is a spelling error which we will rectify. It's Councillor Speed asked for clarity on the Carers Act money, not Careers Act monies.
Yeah, apologies. Okay, thanks for that. Happy to note that item 3B, action log.
Yeah, thank you, Chair. As members will see, we have two items on the action log. The item on the Chief Officer, sorry, 3 items. The Chief Officer update is complete and the finance report is complete. Item 5 on the finance report from the 13th of December remains read with work in progress, and I'll just ask Sandy if he wants to add anything to that.
Yeah, thank you. Yes, regarding that final action point, we have had discussions with the board members that we agree we would have. We've had those discussions over January and February, and we have reached a set of views about how we will work with the deployment of the 24-25 on the spends. My intention is to share a written update about that at our next IJB meeting. I didn't have time to, after we'd reached a view, I didn't have time to build it into today's report. But this will be about passing back about £3 million of resources back to our two parties. It doesn't give us the flexibility to adjust things in year if we need to. There was, in terms of collating the views on that, there was a clear view that we need to make sure that in future years we do all we can to deploy the resource in year, so we don't build up years on an unplanned basis. And we'll confirm that final position when we actually have a chance to build it into the written reports for the April IJB. Small issue about timing in terms of completing these adjustments with NHS Tayside Angus Council, but we'll manage to work that one through. Thank you.
And just in relation to the other one from December 23, that is ongoing and will come back in April after a pharmacy developments or medicines development session, which is happening in March.
Okay, thanks for that. Item 3C, the Chair's Assurance Report and Minute Audit Committee. For noting, any comments?
Yes, Chair, thanks. It's just the usual format of meeting connected to the full audit meeting we had on the 18th of December. It highlights basically the main issues and main decisions that were taken, plus any other points of interest. The actual minutes are appended as attached one as Appendix 1. So if anybody's got any specific questions, I think either I or Sandy can answer them. Thank you.
Sorry, Sam.
Mr. Stephen, just to point out, in that minute, in Appendix 2, I am down as Sam Riddle, Third Sector Representative. Much as I'd like to work for the Third Sector, I don't. So it's just a typo. Yeah. Thank you.
Julie.
Thanks. It was just to pick up on the directions update on page 20 there, that's a topic that's currently being discussed at NHS Tayside as well. So completing the loop, really. Thanks.
Yeah, thanks, Chair. Thanks, Julie, for that comment. Yeah, we have had that review, and we are starting to undertake a review of the frequency and the requirements for us to issue directions, based on the reports that you come to the IGB. We have done a kind of a sense check, and using a different, I suppose, threshold of bringing directions, we might see more directions coming to the IGB in future associated with our reports. So we started that review, obviously reflective of what the audit committee were seeing when they read these papers in December. So I think we will probably see maybe a step change from early summer. Okay.
Okay, thanks for that. Just a small question from me. On page 17, it's talking about charging for services improvement plan, and it's saying that there's an Angus charging group overseeing the completion of the last remaining actions in the improvement plan. I just wondered when that was looking to complete.
Yeah, thanks, Chair. Okay, that group is actually looking to complete that work by the end of March. I think that's the first time I've actually put a date on it, pretty much in any forum. We had a charging, that group meets every week, and my ability to remember the days of the weeks is pretty difficult these days. I have a feeling we met on Monday, if anybody else was at that meeting. I think we actually met on Monday, and Claire Gershie, who's been leading a lot of that improvement work, did say she hopes to complete the outstanding actions by the end of March. It would be fair to say, though, that the general improvement work that we're trying to do regarding our charging processes will be an ongoing process. And also some of that will link into IT improvements that we hope to see fall into place over the next year or two. So although we're hoping to complete the specific actions associated with that recommendation, there will be more improvement actions to come, and we think that will be an iterative and ongoing process for the next wee while.
Excellent, thanks for that. Okay, so we're happy to note that. Item 3D, Chair's Assurance Report, Clinical Care and Professional Governance.
Thank you, Chair. So this is an exception report. The Angus Clinical Care and Professional Governance Forum continues to meet regularly and considers the full range of the risks for the Angus Health and Social Care Partnership and also adverse events complaints. It is a group focused on continuous learning and ensuring a quality management approach. You can see there that the last meeting on the 20th of January, the three risks there that were discussed were mental health and learning disabilities, sustainability of general practice, and the strategic commissioning plan, and further work is required to identify the mitigating actions for these risks. I didn't have any other particular exceptions. Chair, thank you.
Thank you. Any comments or happy to note? Yep. Good, thank you. Okay, we now moved on to item 4. I plan to take item 4 and 5 together, given the kind of link that there is between the two of them. So we'll move on to the lived experience story.
Okay, thank you, Chair. And just for members' awareness, we agreed that we would start to bring lived experience stories to start off the agenda. Just for a variety of reasons. One, so that it is always a reminder for us in terms of why we're here and why we do what we do, but also to try and demonstrate how some of the work that we are taking forward through the strategic plan and the priorities actually is working in practice as well. So we've got that today, and we've got a couple of experience stories that are included in the strategic plan and update. So hopefully members find that helpful. I think Karen's going to go through the story, and then John's going to talk to the ADP report. Thank you, Chair.
Thank you, Chair. Mr A is a gentleman in his 40s, currently resident in Angus, and he's kindly given me permission today to share with you a small part of his life story, his struggles with substance use and mental health, and his recovery journey to date. Mr A's childhood was spent happily, mostly, with his parents and siblings. He does, though, report struggling with his mental health as a small child, and his mother stated that he's always been a very anxious child. He recalls as a child being worried about his mum being assaulted, possibly, and he was also worried about his mum's health and well-being when she was diagnosed with a long-term illness. Moving into adulthood, Mr A married and settled into family life, and he has children from this relationship. Along the way, he and his wife also took on the care of one of his siblings' children. Mr A reflects that this is when his substance use really began. He began taking amphetamines to help motivate him, and he states that this helped him complete practical tasks. He recalls that he drank alcohol throughout the whole of his adult life, but did not consider this problematic initially. However, this did become more problematic some 5 years after his amphetamine use started, and coincided with further caring responsibilities for another family member and the breakdown of his marriage. He states when he first presented to services that he didn't have any hobbies, although he did spend a lot of time with his family when he was sober and low-level drinking. He first presented to services seeking help with his substance use about 12 years ago. He consistently reported trauma in his life through bereavement, family illness, and physical assault and accidents. And at this time, he was seeking help with his dependent and extremely hazardous alcohol use. Over the years, he has consistently experienced dependent and extremely hazardous, sorry, I'm reading the same line twice, apologies, and has reported using other substances, including opiates and novel psychoactive substances. He has consistently stated that he uses these to help him deal with stressful and distressing situations in his life. He's had multiple admissions to hospital for physical injuries received, self-harm, alcohol detoxifications, both planned and unplanned, and general adult psychiatry admissions for suicidal ideation. Every admission to hospital that he has had has included an alcohol detoxification programme, lasting between 5 and 7 days. He's remained in contact with drug and alcohol services over the years and has had episodes of sobriety. Unfortunately, and he will reflect this, these have been very short-lived, and often he'd relapse to drinking quite quickly after a detoxification period in hospital. He frequently voices a wish for abstinence, but has been unable to sustain this following these inpatient detoxes and often returning to alcohol use immediately. In total, he has had 8 7-day planned detox admissions. Prevention work has been ongoing throughout the whole of this period of his engagement with substance use services. However, he will state himself that often he's been too intoxicated to engage. Other lifestyle factors have got in the way, and this has included problematic relationships and partners and his own poor mental health. In 2024, Mr A agreed with staff that all community supports had been exhausted. He was assessed for residential rehab further afield and out with Tayside. This was quite a daunting prospect, leaving his family behind, but one that he engaged in really well throughout the process and was fully prepared to move into residential rehab for a 12-week period. At the end of those 12 weeks, he decided to stay a bit longer and step down into the community living facility because he further wanted to work on his recovery. During his stay in rehab, he reflects confidently about the work that he did there. He made considerable progress, completing all stages of his treatment goals, engaged well in the community and built up trusting relationships with staff and peers, making positive progress. He rejoices that he was seen as a role model within the community. He delivered seminars on relapse prevention, dealing with emotions within the community, and completed therapeutic contract work consisting of family, healthy and unhealthy relationships. He also completed work on his anger management and learning how to deal more with his emotions without utilising substances. He positively contributed to the peer and family groups sharing core issues, and he facilitated several of these groups feeding back and supporting peers. Completed all his goals and his care plan whilst in rehab, and hoped to volunteer on completion of this programme. Throughout his stay in residential rehab, services stayed in contact, and there was a fully planned discharge back into the community for Mr A. Meetings took place with all workers involved, with Mr A being at the centre of this care planning, to make the transition as easy as possible, including working with housing. He had given up his tenancy prior to his period of residential rehabilitation. He saw this as a positive move because there was lots of poor memories associated with the residence that he was living in. The homelessness prevention teams joined us to secure a new tenancy so that he did not have to return to that tenancy. He was pleased with the tenancy he was offered, and he was excited to come home, as it was close to all his family's support. On the day of discharge, ADARS met him at home. His new home wasn't quite ready yet. He didn't have all his furniture in place, so he'd opted to stay with Mum for a week. This actually went really well, and he continued his recovery care plan. He was seen by psychology and was ready to start having planned appointments with the psychologist within the service, and his tenancy was getting organised. His whole family pitched in to help. Within less than a week, he was ready to move into his new tenancy, and he was really excited. He had new furniture, he had new clothes, he had a new look. He felt really good. It did cause him some stress and anxiety, but largely he coped really well using his relapse prevention techniques, which he had learned. Unfortunately, despite all of this, he did relapse some 6 months and 3 weeks after going into residential rehab. However, he can proudly state that that is the longest he has had sober in his life, adult life, that he can remember. What's the future looking like now? Well, Mr A will continue to be offered support by the ADARS team and all our partner agencies to work on reducing his alcohol again and further relapse prevention work. Community groups are always on offer at any time, and we're also still offering support to his family and close carers. He's very reflective that he wants to go back to rehab when he's ready, and we'll continue to work with him. As a service, and along with Mr A, we did quite a lot of reflection as to how does this fit with our strategic priorities for the IJB, and how does this fit, most importantly, with the priorities for Mr A. Angus Health and Social Care Partnership's strategic ambition is to support people to be independent for as long as possible, ensuring services are sustainable and proportionate to need, and that we provide integrated and coordinated care. I hope you've heard a bit today that we have and continue to support Mr A along his recovery journey, assisting him to look after his own health and well-being where he is able. The team have helped him understand and anticipate his needs and have coordinated care across inpatient, community and residential services to help maintain his independence. Throughout his recovery journey, Mr A has been supported to the best of all services' ability to source care close to home, and have attempted to ensure that the right services can be accessed at the right time. His family have been supported to help with his recovery and have been supported to maintain a fulfilling life alongside their caring roles. The recovery journey for individuals can be very complex and long. Services coordinate care and work together with individuals, their families and care providers to try to minimise the harm associated with problematic substance use. Thank you for allowing me to share this story today.
Thank you. That was some real positives in there, as much as there were some challenges as well. So sounds like some really good stuff's been kind of done. I'll move straight on to the actual report, item 5, before I start taking anybody in, if that's okay.
Thank you, Chair. Good afternoon, members. Members will recall that the Angus Alcohol and Drug Partnership Annual Report came to IGB in December last year. However, we noticed too late, unfortunately, that the ADP report attached was from the previous reporting year. So apologies for the delay in bringing it to you today. And a further apology have also been noted for the eagle-eyed among us, I think, that on page 27.6, the proposal is in fact incorrect. So I'll read what the proposal should be, which is that based on the information included in the report, we would propose a level of reasonable assurance to the IJB. Okay, so you'll note that the ADP annual report covers the years 2023 to 24, and it highlights the work of the ADP and also the associated subgroups alongside public health data from this period around alcohol and substance use related hospital admissions and comparative Tayside and national data. I think what's important to note within the report that actually this data is important in terms of highlighting some of the changing demographics that we're seeing in Angus in respect to increase in the use of psychostimulants and also the increase in alcohol use, and that's especially noted in regards to the female populace in Angus. Number of positives contained within the report. Associated treatment waiting times remains good in Angus, above the 90% target. And we are also utilising the alcohol brief intervention role, which is working well. And I think as Karen was speaking there about the lived experience story, we can hear that actually substance use is such a complex area of work, and it does require often long periods of intense interventions, very much around relationships as the key to this, and the need to ensure that we have resources available for support during periods of crisis, and also, as was highlighted within the story, to support rehabilitation. And this is something that the ADP Finance and Commissioning Subgroup have and continue to prioritise in respect to the commissioning of services, and again that's contained within the annual report. You'll note that prevention does continue to remain a priority for the ADP, with good examples in the report of prevention and proactive approaches and the need for future work in this area with links to the Prevention and Proactive Care Group 2. You also note in the forthcoming Chief Officer report reference to the Charter of Rights for people affected by substance misuse. So that was launched during the reporting period. And I can advise that substance use services across the Angus Health and Social Care Partnership are using the Charter toolkit linked to this to ensure the right to the highest standards of care is met and continues to be met. You'll note in the report 2 recommendations for members to consider. I'm happy to take any questions that you may have, and Karen's also here potentially to speak to anything that's more operational. Thank you very much.
Thanks, John, and thanks, Karen. I have to say that lived-in experience, it really does bring to life the reports that we get in front of us. So I think it's a really important agenda item going forward. So thanks to everybody for that. Julie, I'd like to take you in first, please.
Thanks very much, Chair. Thank you both, Karen and John. The lived experience really brought home for me the importance of hope in that process, that never give up, and the services never give up on you either. That's really important, I think. And the words that jumped out for me was rejoice in all of that. And I wish Mr. A very good fortune on his recovery journey, because it is a journey, it's not an end point. And I think people need to hear that, that it needs constant work, and the power of that personal value in that process is just hugely important. But I particularly wanted to pick up on the section in the report about for families by families, because on page 50 there's a mention of that, and both Councillor Speed and I have been very actively engaged with that planning group. And there was actually a fantastic event on the 1st of February in Forfar at the fire station. And the members of this group, including our partners, are family members who are supporting people through their recovery journey. And Karen touched on the family support there. It's hugely important. It can be very isolating when you're coping and trying to help a loved one with an addiction. And the kindness, the compassion, the understanding, and the just willingness to reach out and support more people in that position just shone through. And I really would encourage anyone who is in that position to make contact with For Families by Families, because it's an open door, there's no judgment, people genuinely want to support others through that process. And it's such a kind, loving group. I'm sure you'll agree that I'm really excited about what came out of that event. And kudos to Maureen, Deborah and Mark for helping to facilitate that, and all the family members. So well done. Thanks.
So take Sam first.
It's great to read that 727 alcohol brief interventions were delivered, 3 times more than the previous year. Was there any reason? Well, how did they get so successful?
Thank you, Sam. Good question. Well spotted. It is good. It's an increase. This was off the back of a post funded to support those alcohol brief interventions from that period. So it is good to know that prior to that, the numbers were relatively low. With the post coming in, obviously we've seen that number increase. Apologies, thought I pressed that. No, thank you for the question, Sam. We funded a post through ADP to support alcohol brief interventions. So you're absolutely right. From the reporting period onwards, we've noticed a significant increase in the numbers of alcohol brief interventions that have been undertaken, and that has been sustained and will continue to be sustained, and we'll recognise the value and importance of that role in terms of delivering that support.
I think I've got Martin next.
Thank you very much. Thanks for both of you for the stories. And first of all, I have to declare an interest because I've been involved in Alcoholics Anonymous for 33 years. And I've heard that story for 33 years. And I've heard the relapse for 33 years. And because the missing part, well, it's all well-intentioned and really it is well-intentioned, and I've got a bit of respect for Angus. And the missing part is the discovery that you get about yourself in rehab, and the discovery of why these things are. But the recovery is when you come out of rehab, and it's no be going back to doing the same things, and no be going back to having the same people. There, son, it'll be all right the next thing. Again, it's about personal responsibility. It's about taking that responsibility. And I always use the analogy, and I'm doing something at the Scottish Parliament, the 14. See, I've got a car. I don't take my car to a baker's to get an MOT. If I take it to a baker's, there may be a lot of well-intentioned responses on my MOT. I take my car to a mechanic who has experience in dealing with this. And I'm not knocking anything, I'm only saying I've seen this. There are more people die with alcohol because, one, they sometimes didn't get into rehab, and they have to be commended in this area for doing that. But two, when they come out of rehab, where is the support? No, it's not going back and saying, oh, well, the family will be this and the family will be that. And it's about getting the person into a recovery process. If they want to go through abstention, they go through an abstention channel. Didn't tell somebody, an alcoholic, to take 2 drinks and you'll be okay. That doesn't work. It never has worked. It never will work. Because the disease concept of alcoholism should be studied by people. It was recognised in 1952 by the American Medical Association, and we're still struggling to get recognised in Great Britain. So I commend what was done, and I wish the guy well, but I would get him to AA or any, and there's a good chance that recovery will be gained there, knowing going back to rehabs and going through the same thing over and over again, that everything will be okay. As I say, I declare an interest.
Thanks for that, Martin. And I think you just kind of highlight what a long lifetime complex challenge this is. So thanks for that. Lois, are you wanting to come in next? Yeah.
Yeah, thank you. And thank you to Mr. Ray for sharing his story. One of the things that struck me through the work with For Families by Families has been some of the stories that have been coming through from family members impacted, and their fear of being able to, seek help. Just even some of the stories of people coming to our event a few weeks ago, it was really quite, I guess, concerning that, they wanted to turn round. It was a huge step, even just coming through that door, to seek that support. And I just wondered what is currently being done to try and break that stigma within Angus, so that we can encourage more people to come forward, whether that's because they themselves are struggling or whether it's a family member trying to support someone and not knowing quite where to turn to.
Thanks, Councillor Speed. It's a good question, and it's great to hear both your experiences from being on that group, and it's something that certainly the ADP is seeing huge value in. We do look at a whole family approach to the work of the ADP, and we have involvement from children and families. We have oversight of a number of areas of work, and as already been mentioned, Maureen and our team are very passionate about ensuring that we find ways and means to engage. But your point around reducing stigma, I think, will come through the growth of work like this, when we have families who are able to advocate and speak to other families and say, actually, this is really working for us in terms of coming together. It takes a lot of bravery, and I think it takes a huge amount of bravery for those initial few families who have been involved in this work. This can and should only grow and continue to be that support. So as officers, we'll continue to support that work, and we'll hear from families, actually, because they're the experts in their own situation. And if there's ways and means that we can do more to reduce stigma, we'll do that. There's all sorts of national campaigns, of course, but I think at a local level, so much of that comes through the ability of us supporting families to speak to other families as well. But thank you.
Thank you, Chair. I think, Councillor Speed, just to pick up on that, I think there's a lot of learning for us around the work that Terry and the team have been doing around mental health and the stigma around that, and some of the work being out there in the communities saying it is okay to talk about this, and we are here to support you. So I think there's a lot of learning from that, and how we take that forward within the realms of substance use, I think can only be a positive thing.
Thanks for that. I think we've got Chris Schofield next.
Thank you. Yeah, thanks very much for the lived experience. I think it was really useful, and a story I think I probably recognised from secondary care, where we see a very a recurrent group of people who attend hospital for very similar problems with alcohol and substance misuse. I suppose my question is, how do we in NHS in secondary care get people to the services that they need? Because I think that the biggest risk the detox bit of people coming into hospital and being detox is fine, but the biggest risk to me is that handoff and handover as when they come out. So how do we integrate that service a bit better?
Thank you, Chris, and I think you're right, and this links in with reducing stigma. We do have a no wrong door approach in Angus to mental health, where you can self-refer yourself directly into substance use services. That is highlighted through the Are You OK campaign, where we've got a list of resources available and is promoted. We've done work within our MIU, where people might present as an emergency, with staff trained in how to signpost people to the appropriate services. And we also have GPs' ability to refer through the Mental Health ECS hub. So you might not know all the services, but you do know how to refer into the hub, where there will be somebody contact a person within 48 hours. We say 7 days, but it is within 48 hours, and that person will have direct links into ADAR. So someone might come with distress, but the issue may be related to substance use or a variety of conditions, and that mental health enhanced community support that we have in all GP practices should get people to the right place. So yes, there is potentially work in making sure wherever you are in secondary care that you can tap into it as well. And I think the challenge is to do that through our GP referral guidance at secondary care, and the challenge is getting what Perth and Dundee are doing, because from a secondary care point of view, it needs to be easy to access. So there is a wee bit of work to refine how we support that referral guidance for mental health in across the secondary care, primary care interface. But certainly support what's been said earlier around the value of peer support. And thank you, Martin, for highlighting that. Absolutely agree. And reducing stigma. I did have another point I wanted to come in. Is it okay just to... Thank you. I just wanted to highlight some of the work we're doing around the Prevention and Proactive Care Steering Group you mentioned earlier. And this is around a proposal developing, not just looking at preventing physical ill health and a focus on the life curve, but extending that to have a holistic approach around brain health also. Because many people don't realise the impact that alcohol and other substances have on increasing your dependence in older age, in particular the risk of alcohol-related brain injury or forms of dementia more generally. And so we're really working hard at having that physical, mental health holistic approach and not having things separate for mental health, and that hopefully that approach reduces stigma, recognising that people with substance use and other mental health issues do have impairment of their physical health. I also think the work that we've done in application to the dementia policy team at Scottish Government around dementia-friendly pharmacies, but part of that is having a focus much earlier on the causes of dementia, social isolation, poor hearing, substance misuse. And if we can get that greater knowledge across our communities, wherever you come into contact with a healthcare professional, you can get into the system, easy access, people are not afraid to talk and ask and share the resources available, then hopefully we can have a cohesive approach through the Prevention and Proactive Care Steering Group that tackles all areas inclusively. Thank you.
Thanks, Alison. Martin, are you looking to come back in?
Just thank that's really encouraging. There's the Charity Foundation that have sponsored somebody in Dundee University to do a PhD research on stigmatisation on substance misuse. So that's it's happening. And now I would also point to the Cochrane report and to NICE's recent findings that have put forward abstention programmes are the most successful in treating people with addiction, and they're very worth reading. You've got family support groups within it's Al-Anon that I know in AA. And lastly, the stigmatisation. When I was in America, I've been in America a few times with AA. A lot of the adverts you'll see in the papers in America for working people have got Joe Blogg's 12-step recovery program. So stigmatisation is non-existent. There you actually think you're going to get more work if you put down you're on a 12-step recovery program. Right.
Thanks, Martin. Any other questions, comments? We're happy to approve. Sorry. Oh, yeah, Martin's good. Happy to approve the recommendations as laid out in the report? Yep. Okay. Excellent. Thank you. That takes us on to item 6, Chief Officer update.
Thank you, Chair. Members will see it's quite an extensive report again, and update this time round, covering quite a number of different areas. Just to pull out a couple of things, members will note there hasn't been a Chair's Assurance Report for the Strategic Planning Group for this IJB. The reason being was we had a development session instead of a formal meeting, and we will come on to that as part of the Strategic Planning Update paper within today's agenda. In relation to 3.8 and the Equality and Human Rights Commission, and the reason for bringing it up is just it was something that was also covered at Audit Committee this morning, just around EQIAs, etc. And just to note that the work that we continue to do within Angus is progressing really well, and we will have the outcome of the assessments hopefully soon. On page 80, John's already brought out the Charter of Rights of People affected by substance use, and I think that's something in terms of the Charter for Rights for People. There's a number of different charters out there, and there is something for us to do just around making sure that we are cited on them all and making sure that we are working with those charters in terms of the rights for people. Annual health checks, the work continues to progress. The Tommy Whitelaw sessions, what matters to you, I think just to pull out on some of the data that we're now gathering and pulling out of those sessions. I think the feedback has been really, really positive from everybody who has been in. We've got a couple of quotes there from individuals who have taken part. We do continue to have further sessions arranged, and again the offer extends to IJB members in terms of attendance at those events. We have the Star Awards, the NHS Tayside Star Awards on Friday, and we are lucky enough to have one of the Angus teams as a finalist in the awards that are taking place on Friday. So I just wishing them luck on behalf of the IJB and the Health and Social Care Partnership. And then back to resilience. What can I say? So we've had a storm and we've had an evacuation of a care home, which has not been included in this report, but I couldn't let this report go without just acknowledging two things: the support and the dedication and the tremendous working of all the staff that were involved in that. And it was a really good piece of partnership working between ourselves, Dundee Health and Social Care Partnership, who also had residents in the care home, and the care home themselves, along with other partner agencies who we're getting to know quite well because of the storms as well, I have to say. So I think just to again reiterate the positive work that we're doing in relation to business continuity and resilience is ongoing. So just to acknowledge that and formally pass on thanks, and hopefully the IJB members found the briefings that were circulated helpful.
Thanks, Joe. Yeah, I did actually find them really useful and very up to date, and they must have been trying to deal with a lot of operational things, let alone complete those forms to inform us. Is there any comments or questions, Julie?
Thank you. Yes, those briefings were really helpful. I really appreciate them, and I think our local MSPs and MPs would also find them helpful for future reference, just to include them in the distribution list at the click of a button. I know we've got a homelessness paper later on, but under the rapid rehousing section, I think there's a bit of an ask for us to consider whether we continue reporting the homelessness material to this board, or whether it goes to the Housing Committee. I'm aware John was having conversations with officers in housing as well, but how do you want that conversation to take place? How do we bottom that out? And happy to engage in it.
Thank you, Julie. Yes, so we do have a paper coming up in due course. Suppose for me, and what will be highlighted within the paper, is that the rapid rehousing plan really is the driver for a lot of the work. The work sits within the remit of the partnership, but in terms of where that rapid rehousing is owned, it would seem that the best course for that would be to sit within the newly formed Housing Committee. So I have had various conversations with other officers. I think a decision does need to be made in terms of where that sits. I think if it was a decision for the rapid rehousing to sit within the Housing Committee, then we would obviously expect IGB to instruct that we still have involvement within that group. Obviously, we still have services that are sitting within the partnership that are very much linked to the work of the rapid rehousing and would report to the Housing Committee as well as the IGB. So you're right, I would agree. I think a decision does need to be made about where that goes and how that's taken forward. And I suppose just then ensuring that our commitment still remains in both forums.
Yeah. Okay. And yeah, we've got a paper later on, so we'll make a bit more of a discussion then. So, yes, David.
Thank you. Just two things. One, under 3.2, the unmet need section, there's no reference to residential respite, and I just wonder if we could, in future reports, have that included. I mean, I'm asking because anecdotally, I hear stories about problems with with accessing respite, and I have no context because we don't have that information here. So similar to the description about those who there is a reference to the numbers in residential care, but I think complementary information about access to them and whether there is unmet need in that section or not. I don't know. That would be helpful. Thank you. Second, under 3.10, the GIRF toolkit, is that something that is publicly available at this stage in general terms? I don't know. I've not the remotest idea what it actually looks like, whether it's sitting on a website and you're going to draw it.
So it's something that we can certainly send round. It is on the website, so we can send a link round to that for members.
I've got Chris Boyle and then
Thank you. Good afternoon, colleagues. Just to pick up on section 3.6 of the Chief Officer's report, around the National Care Service, and it reports changes on the 23rd of January 2025. I think to put it in a bit more kind of context and information, there wasn't just changes to the National Care Service Bill. Effectively, a big chunk of it, Part 1, was effectively abandoned by the Scottish Government. Most of the structural reforms contained in the original bill and in the proposed Stage 2 amendments by the Scottish Government, which included renaming integrated joint boards to local National Care Service boards, they've also been dropped as well. And this has been a kind of 7-8 year process now that has cost the country £27 million so far to pursue a National Care Service that many of us, and IJBs included, trade unions, etc., found great flaws and holes in. So whilst there has been, acknowledge that, there has been some changes, they're quite important and very, very significant changes to the direction of travel about a proposed National Care Service. Now, the Scottish Government still support that, trade unions still support the idea of a National Care Service. And my own trade union, Unison, has come up, has written a paper, an alternative vision for the National Care Service in Scotland in association with the Association for Public Service Excellence. There's a lot of good information in there, but I think, to put it in its wider context, the changes and the shift in direction for the National Care Service Bill have been quite ground-shaking, ground-swelling and significantly large to not maybe just be described as changes. There's some significant differences now to what the proposals moving forward are looking like to compare to where they were back in 2016. Thanks.
Thanks for that, and hear what you're saying. Lois, across yourself.
Thank you. Firstly, just to kind of pick up on what was discussed around housing, I guess my thoughts on that would be, or my hopes would be, that there would be some assurance that the link between housing and health strengthens. It's something that I've kind of highlighted and questioned and tried to champion over the last number of years. because I think the connection is so strong and so great. And if we just, look back to Mr. A's example, where, I'm sure throughout that journey, housing often was perhaps a key factor of whether it was going well or not, but also because of the shortages in housing, because of the housing crisis, we are seeing a lot of vulnerable people with health and social care needs and vulnerabilities who are often not in the right place at the right time. So I just really want to make that clear that I would like to see some assurances there. In terms of 3.2 of unmet need, it says there that there's 95 placements for those with learning or physical disability within our care home setting. And I just wondered if for some of those 95 people, some of that could be because either their housing or support needs might not be being met within the community. I would imagine that some of those 95 people might be younger people, and although I do accept that for some it might be that they're in the right setting, however, what is being done to kind of monitor that and ensure that, if they do have an aspiration to be in their own tenancy within the community, that we are supporting them to realise that potential.
Thank you, Councillor Speed, for your question. What I can do is offer you some reassurance that all people are subject to reviews on a minimally annual basis. And at that point, placements are looked at. Is it meeting the person's needs? What is the person's views about that? What are the things we need to do to resolve matters or take matters forward? So that's what we do to ensure that people are placed appropriately. And if people are not, then we look at other forms of accommodation appropriate to meet their needs. Thank you.
Yeah, I think just to pick up on that, and it kind of links with the GIRFE framework as well in terms of how we support getting it right for individuals who we support, whether it be the financial or the actual environment of care for. So absolutely, individuals' needs and outcomes are at the heart of what we will do with families and individuals to support their needs. Just going back to the housing comment, Councillor Speed, absolutely have a assurance around that link between health and housing. It is such an important link. I would actually like to see the reports come in both committees. I think there's a role for both the IJB and the Housing Committee, so not to duplicate work, but I think both committees, the committee and the board, will have different functions, and we need to make sure that we have the right information going to the right committee. So absolute assurance that the link between health and housing will definitely get stronger, and I think it does need to come to both.
Julie.
Thanks. Yeah, it was just to give the IGB assurance. I mean, I sit on the Housing Committee, as does Councillor Speed, and I particularly wanted to be on it because housing is a public health issue. And Jill and I have had conversations around those linkages. So it is for me less about which platform signs things off, but making sure there's a feedback loop so that the right things come to the right body, and that any procurement that needs to be done goes through the right mechanisms, for example, but that we're all cited on it because there's a huge amount of overlap, not just for adults but for children in terms of the child health priority as well. It's vitally important, and we need to capture that. Thanks.
Yeah, thanks, Julie. And absolutely, there's a wider link, just more than physical health. It's mental health as well that housing can impact on individuals and families. So, thanks for that, Martin. Yes.
Thanks, Chair. Just for clarification, under 3.2 in the last sentence, there are currently 23 beds available across care and nursing homes in Angus. Are they available? Are they filled, or are they available to be filled? Or are they unmet?
Chair, I can come in on this. Thanks, Martin. Yeah, those are, at the time of reporting, vacant beds. So no one in them vacant in terms of they can be used and can be commissioned. Thank you.
Okay, thanks. Are we happy to approve the recommendation as outlined in the report? Yep. Excellent. Thank you.
Thank you, Chair. So members have the updated work plan for this year for noting, and there is a draft work plan for 25-26 for approval and discussion in terms of other items that IGB members may wish us to include on the work plan.
Thanks, Jill. Any questions, comments? Nope. Okay, happy to approve the recommendations as outlined in the report. Yep, excellent, thank you. Item 8, appointments to the Angus Integrated Joint Board. Is that me? Again, happy to take any questions, or are we happy to approve the recommendations? I think there's actually one that we need to... See this one?
Yep.
So could I just check for recommendation 6, have we got any nominations?
Yep. Thanks, yeah. Yeah, so we were looking for a nomination for the Audit Committee, and it wasn't a particularly long list of candidates who could volunteer, but the possible candidates have had a conversation. I think Lois is prepared to join the Audit Committee. I think, is it, Lois, okay to say that you're not wanting to stay on that committee for a long time, and I think to some extent Lois and Chris have had a conversation, and Lois is going to join for now, and we'll review it in due course. Thank you.
Be fair in a
Excellent, thank you, and I'm sure you'll find audit an absolute rivet. So it's been a long part of my life, I have to say. Can we agree the recommendations, with recommendation 6 being that Councillor Speed will be the nominee there? Yeah, excellent, thank you. Okay, item 9, finance report.
Right, thanks, Chair. Good afternoon, everybody. Yeah, so this is our latest finance report. I'm just going to highlight a few things, and then obviously happy to take questions from members. First point I'd just like to highlight, it's partly related to the time of year we're at. It's at the top of page 93, and just to remind members that when we're reporting finance reports to this committee, we are reporting what we call a management accounting position, the position in terms of our management positions, but when we actually report information to our audit committee and to our auditors, we'll have a set of financial accounts, the difference largely being related to the utilisation of reserves and things like that. So just to flag that up at this time of year, because that's relatively imminent. That same page, top of page 93, also summarises where we are in this financial year, and we are projecting an underspend this year at the moment of about £3.8 million. That's not far away from what we've been reporting for the last wee while in reports to the IGB and within the partnership. It's fair to say then in much of section 5 we are reporting where we are with individual services, and I know it says as reported previously, we've said this before and things like that, and that's because we are seeing a lot of the patterns that have developed in this financial year continue from where we were earlier on in the year. They continue through to the January and February position, so a lot of it is basically an update on things that you've already seen, so I'm not going to go into that in too much detail. The next section I would like to highlight though is on page 95. It's still in section 5, and it's about inpatient mental health services. There's a couple of big paragraphs there, and they do tie in with recommendations in this paper, and they are associated with inpatient mental health services and the overspends and the recovery plans and the work that we have to do associated with that. We've seen positions like this in the last 2 or 3 years. And we are obviously working with other partners in NHST side to develop recovery plans and plans overall for mental health services. But these 2 paragraphs request the delegation of power and authority to various groups of people, the chair and vice chair and voting members, to just help us reach a position with NHS Tayside and regarding the deployment of reserves over the next 2 or 3 years. So those 2 paragraphs tie in with recommendations on the front page. It's worth saying at this point that we do sometimes ask for your authority to be devolved and to maybe a smaller group of people, and that is often associated with issues that are complicated, although that's not a reason to bring them to the IGB, but it's also things that are often fast-moving and often things that develop on a slightly incremental basis, and that can be quite difficult to bring into an IGB meeting where we have a bit of back and forward, either amongst ourselves or with other bodies like NHS Tayside and Angus Council. Anyway, that's something to flag up about inpatient mental health services. Further on in the report, towards the end of the report in section 7, we note where we are in terms of the likely year-end position. That breaks down some of the fundamental factors in terms of our underspend this year. It explains them. These are factors we've spoken about before. It is about unfilled vacancies. There are issues associated with, in fact, we've just referenced again the level of unmet need and care home uptake. But we have also managed to make progress with some of our savings plans, and some of those things are detailed on the page before. And you can see that some of our recovery plans and other savings plans have made significant progress during this year. So that has all helped to contribute to the financial position and will influence the position rolling forward. So at that point, Chair, I'll stop, but I'm, of course, happy to take any questions.
Thanks, Andy, and a really comprehensive report. Much appreciated from you and your team. Happy to take any questions for Sandy. Such an excellent report. I think we just go straight to the... Sorry.
Yeah, thank you. Yeah, throughout the report, it does talk about pressures and overspends in certain areas, and whether that be kind of psychiatry of old age or the continence service. But when we talk about those pressures and overspends, I guess I can't help but think that it's actually due to those services not being kind of given enough budget in the first place. And I guess, you know, how can we perhaps maybe, is that a case of trying to change that language, or do we need to kind of report in those terms? It's just something that I'm acutely aware of throughout, that actually we're talking about need here and people's needs and people's dignity and human right to have the right support, but we're constantly trying to strip that back.
Okay, thanks, Councillor Speed. The language used reflects where we are in terms of our budget profiles and what we have set up. It is also, I suppose, partly reflective of the overall funding envelope that we have to work with. And if we put more funding in one place, we do have to remove it from another place. We do, though, have, and I accept, we do have some imbalances within our financial plan. Some of them are there's probably various sizes of imbalances. And certainly in the next paper, we do talk about trying to start to address some of the structural imbalances. Those are not necessarily new, some of them. Some have been built into our system over 3 or 4 years. And some of the bigger ones are significant. They're in the £1 million plus territory. So we have referenced that in the next report where we set out our strategic financial planning. But one of our, I suppose, things that constrains what we can do in terms of putting additional funding into any service is the fact that generally to do that, we need to take it out of somewhere else. And that would require a rebalancing. That is quite difficult. But I'd say on the bigger picture of some of these imbalances, and we can maybe speak about it in the next paper, reflect on it in the next paper, there is definitely a reference to trying to address some of those structural imbalances. Okay.
I think just to follow up, it depends on what's driving that overspend as well. So for different services, it's different reasons for the increase in expenditure. So for continence, for example, a lot of that is around the product price. For out of hours, for example, it is based on need. And actually, we know that if we don't have a good, solid, robust out of hours service, the impact on the wider system is quite significant. So there's a different level of descriptors, I guess, depending on what's driving that need. So just to follow up.
Yeah, and just sort of building on that further, sometimes these are time limited, although I'm not clear about that. Some things will be time limited. Sometimes the time limited thing could be a few weeks, and then sometimes it could be half a year. It just depends on the various circumstances. So our response to that kind of thing would be differential.
got Martin next.
Thanks for the report. And just a question with the within older people services, the a lower uptake in care home placements. And then I refer to the question I was asking before, there are 23 unfilled. So is there an option within that, if people are not taking up the care home placements, to redesign that, because the care at home is remaining higher? It's about shifting the balance of the money, because how much does it cost to keep a care home bed unused? What is the cost in that?
Okay, thanks, Martin. So many of the care home beds that we've referred to as being unfilled are not beds provided by ourselves directly. They're beds that we would commission on a week-by-week basis through the National Care Home Contract from the 25 or 30 providers that run care homes in Angus. So when they're not occupied, we are not paying for those beds. And the reference, I suppose, to occupancy in the report before was just to acknowledge that there is a small element of capacity in the system. I think it was 23 beds, but there must be about 900 or so beds in Angus. So it's not a big percentage of beds that are not used on any given day by us. But yeah, we're not paying for those beds when we're not using them. In terms of you wanted to the imbalances in the budgets, in terms of older people services, it's not dissimilar to the question from just a minute or two ago. There is reference about trying to reset the resource funding profile, the resourcing profile for older people services in the next paper. So again, the two things are linking. I suppose that does happen at this time of year when we're kind of towards the end of one year and we're setting things again for a new year. When we're setting the next agenda item, we have the advantage of knowing all we know about where we are right now.
Thanks, Andy. There's a probably point in time at the moment as well, isn't it? So you're starting to see the level of it, the budgeted demand, and then obviously the actual demand at the year end, and this is just kind of reflecting this. The next report, I think, is more about looking at how you deal with some of the questions that have been raised around how do you realign budgets, how do we actually make transformational savings to get a balanced position over the medium term. So thanks for that. I've got Alison next.
It was just a very quick point coming back to what Lois was saying around the concern around unmet need and having the financial underspend. I just would like to highlight that addressing overspend doesn't necessarily mean that we are reducing service provision, and the 2C practices would be an example of that. We've reduced the overspend by probably £1 million potentially, and we've done that through increasing staffing and redesigning the model. So it does take a lot of work, but I think we should make sure that we're looking at services from a quality management perspective, and where we've managed to achieve that, and similar for continence provision, where there's variation across different areas. It's where we've managed to invest in staff, prevention, proactive care, well-being of staff, and looking at the model of care. That's where we've been able to make the cost effectiveness and value for money changes.
Thanks, Alison. You're making an important point there as well, that the finance tells one story, but there's an operational story or a kind of delivery story that sits behind those numbers. So thanks for that. Julie.
Thank you, Chair. And Alison's actually answered to the first half of my question around the 2C practices. It was, I guess, about getting a sense of the stability there, despite the saving, if you like. So you've really kind of covered that off. Thank you. I wanted to ask about the out of hours report that is going to be coming to a future IJB meeting, to get a sense of when that might be. And also, will we be able to demonstrate any themes that are emerging around the triage process in the out of hours period, to make sure, are people coming to out of hours because they can't get in somewhere else, and also the level of clinical safety and confidence we have that they're being triaged to the right place, in order to provide that kind of background around what we do need to deliver if it sits out with the out of hours service. Thanks.
So members will be aware that we had said that we would bring a kind of modular care paper back for out of hours early 2025. the timeline, so there's a lot of work that's been done on that, and a number of options that have been looked at, and individuals have gone out across all 3 partnership areas to start to work up those options even further. I think one of the exciting things that's happened probably just in the last few weeks, and it does pick up on what you were saying there around triage and access to services, through the work around optimising access, and that's not just access to secondary care or acute facilities, it's access across primary and community care. We're working up quite an exciting, quite a transformational, I can see Chris nodding, and I'm sure Scott is nodding as well, from PLT. Quite an exciting piece of work actually, that will expand the Flow Navigation Centre from Outwith ED, and how we can learn from what's there and how that would translate to a community type model. So essentially a Flow Nav Centre plus for Tayside, with a single point of contact across all 3 partnership areas. So very early in the discussions around that will mean that because we want it to be a 24/7 model, it will impact on the timelines, and it might not be an out of hours model, a care paper that we actually come back with. It might be something quite different. So I guess I will update, watch this space. I don't know, Chris, if you want to add anything to that, or Scott, but genuinely there's a lot of excitement in the system around this, and there's a lot of national interest as well from Scottish Government around that, and the unscheduled care team too.
Chris?
Yeah, thanks. Yeah, this is a really exciting opportunity to do something completely different. This concept of potentially splitting the elective and urgent care flows for the betterment of both of them would be something that I think that the rest of the nation might look to as an exemplar system. So very happy. NHS Tayside's very excited about this, and I'm sure Angus Health and Social Care Partnership are.
Thanks, Chris. Yes, Ron.
See if I get this right. Thanks, Chair. Just a quick question around about, it's in with the current position on bullet point 5. The above pressures are offset by a range of service underspends, mainly relating to vacancies linked to recruitment challenges. So could I ask what these vacancies are and what the plans are? So you're saying you're going to make a saving from that. So we're saying we're no longer require these posts, or what are they also? Sorry, where was I? What part do you want? Okay, so can I ask how the planned saving interventions impacts on patient care, the whole system, inpatient services and staff's terms and conditions, etc. Because obviously I wouldn't be supportive of what could be deemed as no recruitment. Okay, if we're just going to say we're no longer needing that anymore. So understanding what these roles are that have been hard to recruit. Cheers.
Thanks for the question. This report does reflect that throughout the year we have had vacancies within a whole range of services, and it's pretty much across the board. I don't know if Eunice might want to come in a second about things that we're doing to try and recruit, but in terms of what we're reflecting here, we're reflecting what's happened, and it wasn't a plan for us to necessarily be having these vacancies. We know it's been the reality of the last 10 months that there have been these vacancies. They are still in our system, so we haven't taken these posts out of our system at this stage. We do expect a level of vacancy to probably continue until we resolve recruitment issues and things like that. So it's in my head, I suspect some of these will continue into the new financial year because of the size of the list of vacancies, but we haven't been taking vacancies out of the system on a structured basis in terms of what we're setting out here. This report here is very much about the year that we're in, and a comparison with where we expect it to be. So we have said we have a level of unmet care home need home care need that we've spoken about already. We expect it to be there, but it's been running below that. We have said that the level of care home placements is less than we expected it to be. And at the moment, the level of posts filled, because of the unfilled vacancies, is lower than we expected to be. So it's just a comparison with our plan in terms of this year. Hopefully that makes sense. Yeah. Okay.
Oh, is that me now? Sorry. Just to offer a level of assurance, we've done no freeze on recruitment at all. We do have a lot of scrutiny around our recruitment and due diligence about the posts that we are recruiting to. But we are actively recruiting. We've done quite extensive work around our recruitment campaigns, and we've just actually published a briefing video for different services to use around how we want to promote roles within Angus Health and Social Care Partnership, the benefits of coming to work in Angus, and also some of the professional skills that we need and things that we'd want to highlight through recruitment. So we're very active around our recruitment, and we've got a specific subgroup of the workforce steering group around recruitment, but also retention, because we also want to keep the staff that we have. In terms of inpatient care, I don't think it's been affected. We are really quite creative around how we use the staff groups that we have. We have, had to redeploy people at times to make sure that there's no risks to patient care, and that's something we would continue to do if there's gaps. There's also national challenges around recruitment. So with the best will in the world, we know that for some professions, there's not enough people going into university and college places to fill some roles. So that is something we are looking at, for the future. Can we look at different roles? Can we develop schemes in-house to support our current employees to retrain in some of the professional jobs that we require? So there's lots of activity around recruitment. So hopefully that's offered some reassurance that is very much a strong focus of the work that we do within the partnership. Thank you.
Thank you. Any other questions? Nope. Happy to approve the recommendations as in the report. Excellent. Okay. We'll move on to item 10, and I'm proposing that we stop for a comfort break after this item. So if we're bursting for the toilet, you've got to be quick. So back to yourself, Sandy.
Okay, thanks, Chair. I'll be quick. Okay. I didn't need to go, but right. So this report is an update of where we are with our financial planning position. We've tried to use a similar format to what we've shared in previous years to ensure that board members can access it, and you'll find it relatively accessible in terms of understanding what we're putting in front of them. It's essentially an incremental build out on where we have been before, but we do plan to bring a further iteration of this back to the committee in due course. It's fair to say, and board members will be aware, there are significant challenges affecting all partnerships, all councils, health boards, and we see that coming through this report today. I'm going to pick up on some of the issues in this report, particularly associated with recommendations 3 and 4 as I go through the report. It's also worth noting we have shared the building blocks for this financial plan with the Strategic Planning Group, and also at an IGB development session at the end of January. So hopefully this feels like a logical flow on from that. The areas I particularly just want to bring to people's attention, the first area is on page 107, bullet points 5.24 and 5.25. And this refers to our budget settlements with our partners, particularly our budget settlements with NHS Tayside. And it notes that at the moment, we're still having ongoing discussions with NHS Tayside regarding the funding settlement for 25-26. That's obviously a big part of our overall financial plan. What we now know is that the proposed budget settlement from NHS Tayside is going to come in at, the proposal is that will be for a lower funding settlement than we were originally envisaging, approximately £900,000 lower than we were originally envisaging, so quite a significant amount. NHS Tayside have been looking at their overall financial plans and have been looking at the funding that they provide to health and social care partnerships across Tayside, and have felt that this is a necessary adjustment in terms of expectations that they are looking to make. We are, as an IJB, in communication with NHS Tayside. We've written to them and shared a few concerns. We have shared where we are on this issue with the voting members and the Chair and Vice Chair as this issue was developing. We did that 2 or 3 weeks ago. And of course, this will be something that we will keep an active dialogue going with NHS Tayside until we reach a resolution. We have said that because it's not resolved, we are looking to continue to work through a solution, and that's why we've put in section 5.25 of the report, which is requesting that the members devolve authority to the group of people, Chair, Chief Finance Officer, Chief Officer and the Vice Chair, to develop those and continue those discussions on behalf of the partnership. So that is a significant issue for us. And one of the recommendations built in here is that should a budget settlement approval be required before the next IJB meeting, then we may need to require a special IJB meeting in the intervening weeks. So that's the first key point to note. The second key point to note is actually going back a page 106, and it's about national insurance contributions, a subject of much discussion in the media at the moment, and many of you will be aware of the challenges across the economy regarding this. It's been a very fluid position in terms of national insurance funding, but the assumptions have moved on since we developed this paper. We now expect to receive funding equivalent to about 60% of the costs of the national insurance impact for staff that we directly employ. But we do not expect to receive funding to support any national insurance implications for the likes of commissioned services or independent contractors that we work with. And that's a position common across all partnerships, health boards and council areas. So that does have an impact on our financial plan. And in terms of some of the directly employed staff assumptions, the plan is going to have an extra pressure in it of about £400,000. So it's important to keep that in mind. It's a very fluid picture in terms of even the funding side of things. That's still moving a wee bit. But I want to take that issue forward in the paper and take you to section 5.33 and page 108. And this talks about our response to that same issue, our response to the national insurance issue. So what I was speaking about a minute ago is how we are going to be funded. And these two big paragraphs on page 108 under national insurance talk about our response. So we know this is particularly our response in terms of working with our commissioned services in the third sector. We know we commission and contract to about £60 million of services in Angus, all provided through, I say, independent providers and the third sector. We estimate that the national insurance impact for those providers and the third sector could be in the region of about £1.8 million. That's a slight update on the information I had in here as more information has become available. That includes things like the National Care Home Contract, home care, and a range of other providers that we work with. Also includes, as well as the National Care Home Contract, which we don't organise ourselves, contracts that are managed through Scotland Excel on a national procurement basis. We have some of the impact of this already allowed for as a risk inside the financial plan. So some of that is in fact, it's about partly half allowed for. However, we do, because this is a very developing situation, we are continuing to work closely on this issue. We've undertaken a survey with our providers to see where they are. We have a short life working group set up that includes representatives from finance, service leaders, heads of service. It also includes representatives of our procurement and contracting teams who link in with Angus Council. Kirsty, we're hoping that we'll be able to work alongside Children's Services in developing solutions for this. And we've also got Gemma also going to be participating in those discussions. So through that group, we hope to develop our planned response for this. And that's reflective of some of the recommendations in this paper. In developing a planned response, we're obviously mindful of the financial impact on us as a partnership because we aren't receiving funding for this. And obviously our efforts will be partly focused on trying to contain the financial impact for the partnership, accepting there is a financial impact for the providers. But we're also conscious of the risks that we've noted down in this paper, the strategic risks, which include the unmet need issue, but also include the risks associated with the sustainability of commissioned service providers, because they are a key part of the landscape in Angus, and we will need to keep that in mind very much as we develop our response to this. So we've set out recommendations associated with this in the front of the page, and assuming we do develop a plan and we are clear where we're going, the impact of that plan in terms of financial impact will be reflected in the final iteration of this strategic financial plan when it comes back to the board. But as I say, we have built some of the, there's an element of financial allowance built into this already, not necessarily at a full exposure, but just an exposure at the moment. But things are quite fluid on that one. I'm happy to take questions, of course. I'll quickly cover some other issues. And ironically, the other issues are quite important as well. I'll skip over some of them. In terms of a summary of where we are, you can see that in section 7.3 on page 112. There's a table there that sets out the financial position, and we have a headline figure that suggests maybe a £5 million overspend next year, rising to £10 million in the year 27-28. However, we have a series of savings plans that we are already planning to do. We aren't making as much progress on some of them as we would have perhaps anticipated or hoped, but we are absolutely committed to delivering them through the management teams. We do expect some level of non-recurring savings coming through even next year, and I think that's because we expect there still to be vacancies in the system. They're not going to magically solve themselves as we roll from one year into the next, and even things like unmet need. We expect there realistically to be a level of unmet need at the start of the new financial year. And we also know that we can rely on, for now, we can rely on reserves on a time-limited basis. So this plan, on page 112, suggested we might be able to show a balanced plan for the next couple of years. However, the points I have highlighted earlier on are going to change that significantly. A budget settlement impact that's not as we planned will be different, and that will have an impact on here. The national insurance issue will also have an impact on here. They're the two big things. They will change this quite significantly. I expect to be able to brief board members perhaps at the end of March in terms of where we are, and obviously that will all be wrapped up in a final assessment of where we are. And then just kind of taking that point on to 7.6.3 on page 113, we clearly see significant shortfalls emerging in this plan. That was always the case. We brought, I thought, quite a helpful paper to the IGB in August 2024, setting out the first set of responses to that widening gap. And we are looking for a series of proposals coming back to the IGB in June to also help describe how we would close out the strategic financial planning gap. At that point, I'll stop, and of course, I'm happy to take any questions.
Okay, thanks, Sandy. I really was going to say good report. Good report, I've seen comprehensive rather than good news, and it's always a challenge looking at this kind of period. I mean, the level of geopolitical challenges that are sitting out there. We've got Scottish Government elections coming up. So yeah, some real challenges for the IJB going forward. But I think from my perspective, it's kind of clear the need for identification of recurring savings going forward. And that's the only way we're going to get ourselves into a kind of stable financial position. So for me, that's going to be one of the keys coming back in June is where that is likely to land. Happy to take questions.
Yeah, thank you. Probably just following on from kind of your thoughts and what you've just said, how will that then be balanced with upholding people's kind of needs and rights and the person-centred approach that we are promoting to ensure that we are still delivering good care at the right time, in the right place?
That's a really difficult question, Lois.
Yeah,
Jill?
I think we'll have to be honest. Councillor Speed, we don't know the answer to that at the moment, and I think we're not the only IGB Health and Social Care Partnership that are grappling with that absolute challenge. We have to provide the care that we can, and we absolutely will continue to try and do what we can to the best of our ability. All of these things are completely out with our control. What I would say is that there's a number of discussions going on with Scottish Government and COSLA and the National Chief Officers and Chief Finance Officers, including third-party providers, independent providers and independent contractors, because I think we need to acknowledge that this will impact on primary care as well. There is no other money in the system unless No. Okay. So just just to say that there's a number of things that we're trying to do, but nobody has the answer to that.
And yeah, just to come back to say, I fully appreciate the position that you've all been put in. You know, it is really concerning. And, you know, to not even be able to really, even at this late stage in the day, be able to plan for, you know, the financial year ahead, never mind a 3-year projection. So absolutely. And I guess my concern is ultimately for people within our communities, but also the workforce who are already under significant pressures, and we know that through, you know, a lot of the challenges and absences as well. So, yeah, I am not a good position to be in.
Yeah, thanks, Councillor Speed. The position is really dynamic. I mentioned some of the funding arrangements for national insurance, not our response to the national insurance, but some of the funding arrangements. And we had clarity about some of that only on Friday afternoon. So it is a really dynamic position. And you know, that is reflective of what we can see in the media and all the various impacts on the various sectors of the economy. I think, I mean, sorry, Lisa, I'm just going to refer back to the minor injuries paper from earlier on, because, oh, sorry, later, it's not happened yet. Well, I'll maybe won't refer back to it. So I have read it earlier on today. But you know, we talk about the engagement we're going to do in that paper, and that kind of thing is really quite important to make sure for the bigger decisions that we're making, that we do all that kind of consultation and try and make as good a set of decisions as we can, bearing in mind the situation that Jill's just described.
Sorry, yeah, because I had raised previously in an IGB about consultation on our budget as well, which is something that I think would be good to see moving forward into the new financial year, that we will plan that consultation engagement with communities for next budget as well.
Yeah, thanks, Councillor Speed. I think there are varying ways of constructing a budget, and I'm aware that a number of organisations, and I include probably Angus Council in this, and many councils, they will have a whole set of proposals kind of coming together, coming to fruition and coming to a particular meeting at one particular point in time. And that is the way, obviously, a lot of local authorities are dealing with things like their overall budget setting and things like the council tax setting. We're obviously able to, we'll have many things that are developing at different times in different years. Different times in any given year. And if we are able to make incremental decisions throughout the year, for example, we might agree to do a change here, a change there, and change there. I don't think we necessarily have to be beholden to building everything around a particular meeting in January. We can develop things incrementally. The strategic financial plan is a strategic financial plan that will last multiple years, and we can build things into that all the way along. But that's talking about a specific kind of consultation around a specific paper. I feel instinctively that we're better to probably build our consultation around individual proposals. That may not prove to be the best way. That's just how I'm feeling at the moment, if that kind of makes sense.
I was actually just going to say that I think what we will be focusing on in the next financial year is the constant engagement around specific pieces of work, rather than going out to consult on the makeup of the overall budget. It's something that we can take away and have further discussion about, though, but we will give assurance around the consultation engagement around pieces of work.
Thanks. And just before I take Tina in, I mean, again, I assume as proposals come forward, we'll have an equality impact assessment, which by definition will require communication and engagement anyway. So I'd expect to be seeing that. So, sorry.
Thank you, Chair. It's just in relation to recommendation 4 and the wording of that. I was just looking to understand, Sandy, the possibility of a financial limit on that, and what the limit to the delegation would be. What do you envisage for that?
Yes, so I mentioned before, I should maybe these 2 points. There is an element of allowance for this recommendation is about.
Sandy, sorry, your mic's not.
Sorry, this recommendation that you're asking about, Tina, is about our response to the national insurance issue. I mentioned that we have an allowance already built in for some of the cost of the national insurance response, But we think the upper threshold of possible exposure to our providers is about £1.8 million. It might move around because we're not in control of that figure exactly. So the maximum level of threshold that we would be possibly exposed to, and I mean possibly exposed to, is £1.8 million. However, I did say, as I was describing how we will work things through our short life working group, we will be doing what we can to contain that cost exposure through the short life working group, and at the same time trying to balance the issues of sustaining our provider, sustaining our providers, as well as trying to kind of limit the impact on the financial position for the partnership. So that's a top-end exposure, but we will be doing what we can through the short life working group to contain that.
There's no suggestion by you of amending the wording of Delegation 4 to contain a limit in terms of the Chief Officer's remit?
We could put in the limit of, I mean, the thing is, the figure we have at the moment of £1.8 million is an estimate. It could be fractionally out because it's not a figure we directly control, but we could put in a limit that is that figure.
It's really what members are content with and happy enough to delegate to the Chief Officer, rather than having it come back to the IGB. It's for members to consider what they're comfortable with.
In that case, can we get a reminder of what your delegated authority is?
I'm not aware that you have a specific level, but
discussion team, there isn't a formal level, Councillor Bell.
I think probably from my perspective, whilst it's an unknown, it's a known unknown, if that makes sense. And I just wonder, if you try to put a limit on it, if it is slightly out and we have to come back, it's just going to delay the uncertainty for those providers. So I'd be kind of comfortable as it is at the moment. I don't know about yourself, Jill.
I was just going to say, for members, if we are coming together for a special IJB for a budget settlement, there might be an opportunity to have it as a two-item agenda and bring this back.
I've got Chris first, I think.
Thank you, Chair. Just a couple of things on Sandy's report. I think the first thing I would want to do would be to echo Councillor Speed's thoughts and sentiments earlier on around changes, cuts, savings, etc., and their impact on communities and our hardworking staff members who deliver those services to some of the most vulnerable members of society here in Angus. So I'd absolutely endorse what Lois had said there. We only have to look northwards to Aberdeenshire IJB to see the transition from savings on a spreadsheet to real cuts to services to people in our communities, in the effect that those cuts will potentially have on residents there. And I have to say, I'm nervous for the future, and look at the figures around potential shortfalls for the years ahead. Makes me nervous, makes me worried about what that's going to look like. And there's a important bit about language here as well. Savings always sounds very positive, doesn't it? I'm saving up for a holiday, I'm saving up for a new car. But cuts are totally different things. Cuts are services and facilities being removed, for example, to the detriment of communities and the people that work to provide those. My second point would be around page 107, 5.33 on inflationary pressures. It talks about pay inflation. We say in our delegation to Angus Council every year that budgeting for a pay rise that doesn't even match inflation, 3% is not a realistic budget. It's not employees' fault that the local authorities have been under sustained pressure for years and years to cut services and to cut staff. And when we're looking at a 3% assumption for a pay uplift for this year, we can look at other figures to suggest equally why that is too low. The energy price cap we've just heard about yesterday, up by 6.4%. I think the figure I'm away to quote now about council rents are going to go up by 5.2% this year. Staples such as coffee up 21%, butter 18%, fish 7%. So, you know, budgeting for below inflation and below real cost of living pay rises is unfair on our workforce wherever they may work, because it's not their fault that we're seeing year and years of cuts upon cuts. There's a couple of assumptions in there as well in Sandy's report, and I know it's not for the IJB to consider, but I really want to flag this up as well. There's an assumption that any more than 3% the NHS, the Scottish Government will fund, but there's no such assumption for local government. Parity would be absolutely fantastic, but thank you for taking the time to listen to my comments. Thank you.
Thanks for that, Chris. I'm sure Sandy will take that on board. I mean, it's always a difficult one, isn't it, to try and project what you think the pay award will be. And obviously, that's just a local assumption. It's a nationally agreed pay award that's dealt with. So thanks for your comments. I've got Julie next.
Yeah, it's a comment really, and I guess I wanted the IJB to be aware that when I have the opportunity at a national level, these are issues that are constantly getting flagged up, and particularly around the ambitions of the Scottish Government that the First Minister announced a couple of weeks ago. If we don't have the infrastructure in place through the health and social care partnerships, that's going to hinder ambitions at a national level around increasing procedures, you know, getting waiting lists right down, and just last week with Public Health Scotland, I think we have a real role in Public Health Scotland around the reality of the situation. If we cannot keep that flow going, and if it's around investing directly in community-based services in order to facilitate the acute sector ambitions, we're going to get caught up, and patients are going to be in a loop. It's going to undo the amazing work that we've done around discharges without delay, and making sure that people do have the right care in the right place at the right time, but then they move on, and hopefully they move home and are supported at home. And I think that's really important. It absolutely has to be a whole system approach to this, otherwise it won't work. And I know those are the conversations that we're having at the Health Board as well. I think Angus Health and Social Care Partnership and IJB are in a really good position compared to very many others, some of them not too far away from us, including Chris's point, and that's all credit to Sandy and the team around keeping us sighted on everything as well. So I really do appreciate that. But there are, and I'm sure Jill is having those conversations with her peers around the Chief Officer network too, and COSLA, absolutely. So it's not being ignored anywhere, but it has to be a collective approach to it, I think. Thanks.
Yeah, thanks, Julie. I would agree. I mean, the whole system approach is just absolutely fundamentally critical, isn't it? I mean, we talked about housing earlier on, for example. The link between housing and health, you know, everybody understands that. So whole system has got to be the approach we take. So thanks for that. I think I've got Martin next.
Thanks, Chair, and thanks for the report. I'm looking at 13.1 on page 114, and it's on directions. It's about the strategic commissioning plan are given as directions to NHS Tayside and to Angus Council. Have they got the capacity to undertake that, the strategic commissioning plan? Who's the accountable officer within the strategic commissioning plan? Because this always confuses me. Like, you could put directions to NHS Tayside, you could put directions to Angus Council, and they say, oh, wait a minute, that doesn't fit in with our plans. So then who's the accountable officer for anything that's contained within the Strategic Commissioning Plan? Because you've got 3 IGBs all putting in separate strategies, different strategies. Just seek clarification on that.
Thanks, Martin. That's a really good point. I think we had a session with the Chief Executive of NHS Tayside the other day, specifically on that, and I think would echo what she said, which is it's about collaborative working. So it's rather than a kind of diktat from us, there's that partnership working that sort of everyone agrees on the right direction, the right kind of wording for that direction, and everybody's then signed up to that. So certainly within NHS Tayside, once a direction's made, my understanding is that the accountable officer is the Chief Executive. I'm not quite sure who the accountable officer would be on the council side, which is a bit ironic given that's where I spent 30 years of my life, but maybe Jill can answer that.
Cheers.
So, Martin, I think topical question. I think at the moment, given some of the discussions that are going on. So, Steve's absolutely right. So the Chief Exec from an NHS perspective is the accountable officer. I don't have accountable officer status as a Chief Officer of the IGB. Sandy does have accountable officer status as Chief Finance Officer under Section 95. So I don't, however, I am accountable to deliver the service. So I have a kind of dual role, so I'm Chief Officer for the IGB, but I'm also Chief Officer of the Health and Social Care Partnership, which is the delivery arm. So essentially, the IGB would direct NHS Tayside to deliver something. That direction would go to the Chief Exec as accountable officer, and that would come to me as the Chief Officer of the Health and Social Care Partnership to deliver that. So I'm delivering it on behalf of the partnership through NHS Tayside, or indeed Angus Council. I'm not delivering it as Chief Officer of the IGB.
You could actually put a binding direction onto the Chief Officer of Tayside or the Chief Executive. You put a binding direction to them. So you're actually saying this has to be done because it's binding, and they're going to say, no, it's not, because that's going to affect me. So where does that unravel?
Okay, so it unravels in terms of how we get to the point of getting to a direction. So before we even bring papers to the IGB, we need to be making sure that we're working collaboratively across the system so that we're really clear what that impact assessment is on an integrated perspective. So as an IGB, we may make a decision, but actually we have to be really clear around what the impact on another part of the system, whether that be through our council, local authority colleagues, or from an NHS perspective. There's a bit of work that myself and one of the other chief officers are undertaking at the moment, is looking at a template for an integrated impact assessment to support decision making for those exact reasons, Martin, because given the level of challenge financially for us all, the risk is that we all just go back into working within our silos, and the reality is we need some fundamental, real transformational change, and we've been talking about transformational change for such a long time, but we're at a point now where if we don't do this together, the impact on what you were speaking about, Councillor Speed, and Chris as well, that is going to be our reality. So we have to work together. We have to look at what the impacts across the system are actually going to look like and what they're going to be, so that when we write the directions, there's no surprises in those directions, and that we should not be in a position where we're directing our partner organisations to do something that they can't do. So it's all in the workup, I think is what I'm trying to say, but it is a huge challenge.
Thanks. Yes, Ron.
Thanks, Chair. Without going over everybody else's comments, but probably just to reiterate some of the other stuff, it's been said already, the importance about working together, all right? So I hope we can improve on the partnership, working from from an NHS staff side point of view, okay, and we continue to do that. I appreciate the landscape we're in, however, that's imperative that we get that right, okay, and everybody's involved with any decisions moving forward. Thanks.
I think just to give assurance, Ron, we can't deliver what we need to deliver without staff and without people. So if we don't work in partnership, then we're going to be in a really even more difficult position. So you have absolute assurance from both NHS Tayside and for council employees that we have the best interests of staff at heart, and we will work with yourselves and staff in terms of the work that we need to do, and we'll do that together.
Lewis?
Yeah, there's probably lots of questions that we could all keep going with regards to this paper and the concerns that we all have. But I guess I just wondered if I could have a brief kind of explanation around the saving in term and the realignment in terms of older people and what that actually will look like in reality on the ground for older people across the various settings. But also on that as well, and just on the back of working together, I think absolutely 100% we need to be supporting you know, and we're different roles, the workforce and our communities, but also the ability to be able to have that freedom to express concern. And, well, I've done it previous year where I couldn't support the budget proposals. And in many ways, this paper actually feels, well, is a build-up to obviously what's coming. And the wording within that is warming up. So there is, within the recommendations and the content of the report, things that I can't agree with, and as Sandy has highlighted in some of our correspondence and in previous meetings, you know, I don't support the kind of handing back of monies given the financial position that we're in, albeit accepting that there has been challenges and reasons as to why there is surplus money, but yeah, I don't support that. So I'd probably want that to be kind of recorded as well. But yeah, on the older peoples, thank you.
Okay, thanks, Councillor Speed. And the comments you've just made will certainly capture, when we build it into a finance report documenting what we're doing with that funding, we'll build in those reservations that you had. So it talks about the recommendation I think you're referring to as the first recommendation, improved resource profile for older people services. So I think the easiest thing for me to do is refer to the paper that we spoke about a few minutes ago, the finance report, and that suggests at the moment, older people services budgets in Angus will underspend by over £2 million per annum. Now, some of that is to do with unmet need, and we're not taking the funding out for unmet need. We've been working with the service and John and service leaders to make sure there is funding there to pay for that need when that need can be delivered. But we have been looking at the patterns of requirement of funding over quite a period of time. We've reported them in this forum for probably a couple of years that there's been underspends on older people services. And we feel, I don't think we're being particularly aggressive is probably not the right word, but it's a relatively safe adjustment, I feel. It's a relatively conservative adjustment. There will still, I mean, at the moment, there will still be projected underspends in older people services next year, even though if we made the kind of adjustment set out in this paper. So I don't think we're being unrealistic in basically resetting these budgets. And it's adjustments like that where we are able to kind of embed and underspend and say, we'll move that out, that we will be able to put that into other services to say, they're not quite as overspent as they would otherwise be because we can put some more funding in there. So that's what we're trying to do. We're just trying to rebalance. But I don't think it's too aggressive. Okay.
Any else?
Yeah, just from a clinical perspective, I would support that. Our model of change for our model of care for elderly people has changed significantly over years, and we've just seen in February with a considerable demand on the system that the system was able to adapt with flexibility. So and still beds available. So I think that I would support this on the basis, as Sandy has said, it's because our model has changed of looking after people much more earlier in their journey. We've got enhanced community support embedded in every general practice, and I feel that the changes proposed are, from a clinical perspective, the right thing to do is we refocus care in people's own homes.
Okay, in terms of the recommendations, if I've got no further questions, are we going to look to reword number 4?
Tina, just in terms of a reword of I
didn't get the feeling from members that that's what they were looking for. I think I've said that my suggestion would be putting an upper limit on that so that the delegation to yourself is quite tight as to what you can and can't do, but it's a matter for members.
Okay, so I think the two options are putting an upper limit on or requesting it to come back to special IGB. I think is the two options that are there, and then we would need to agree a form of words.
Yeah, I mean, I suspect that given that we're coming back, even if...
Sorry, or it can be granted as is. Those are the three options. It's just for members to make that decision.
As it's actually going to be effective from the 1st of April 25, and we're going to be coming back before the end of March, potentially, I'd be comfortable going with the recommendation that's here on the basis that, to all intents and purposes, it wouldn't be kind of kicking in until the 1st of April, because obviously that's what it relates to. We're going to be coming back in March. So my kind of view would be we'll leave the recommendation as is, and we take the report in March, and then we'll have a further report, I think, in April as well. So we'll be able to pick it up through that if everyone was comfortable, but I'm kind of open to thoughts.
Sorry, yeah, I thought perhaps we could request that a report comes back in the March or the special that we might have to call, rather than kind of set or pluck a figure. I'd be more comfortable that you bring it back and then, but that's just my thoughts.
Sorry, that's exactly what I was kind of sort of thinking, was that when we come back in March, we'll have a paper that sets that out in a bit more detail, a bit more granularity, and we can work out what if there's further delegation.
I wonder if we maybe take that comfort break and then work with a form of words that we can come back to the report after the comfort break to agree on, if that's okay for the recommendations.
Can we stop the live stream, please?
Stop for, do you want? Okay, thanks everyone. Okay, we're on item 10 and we're looking at the recommendations. So during the recess there for recommendation 4, proposing to add at the end of that paragraph up to a £2 million limit and an update to be taken to a special meeting of the IJB. Is everybody kind of comfortable with all the recommendations, including that addition? Kind of conscious Lois is... Maybe just repeat that for her.
There was a key.
So we're just looking to approve the recommendations, and I just said there, Lois, that for recommendation 4, if we add in at the end of that paragraph up to a £2 million limit, an update to be taken to a special meeting of the IJB, and we approve the rest of the recommendations. So this is to do with recommendation 4. So we're adding an upper limit, and it will be reported back to the special meeting, hopefully by the end of March. Everyone content with the recommendations as amended?
Thank you, Chair. So this report is a combination of updates on all 3 priorities. Members will be aware that we have tested out a new way of bringing updates to the IJB over the last year, so that we can have a more focused and detailed discussion on individual priorities, and we've started to try and bring the local indicators into that so that you can see the outcome of the work that's ongoing. So this is a report that brings together all 3 priorities with a bit of an update based on where they were at previous reports. There is something for the IJB to discuss today in terms of proposals, and that was the subject of the strategic planning group development session. So if it's okay, Chair, I'm just going to invite Sally to talk us through the proposal section.
Thank you. So yes, the timeline for our current plan is 23 to 26, and in line with our statutory duties, we do have to review our plan every 3 years, and in carrying out this review, we must have regard of the integration principles and the national health and wellbeing outcomes, and also have regard to the strategic planning group. And obviously, we need to refresh our strategic needs assessment and of course, seek the opinion of stakeholders, especially members of the public. So there are basically 3 potential outcomes of the review. We retain our current plan, we revise our existing strategic commissioning plan, or replace the existing one. So we're in the process of planning our engagement and looking at how we refresh our strategic needs assessment, and we propose that we come back in August with the progress of where we've got to with that.
Thank you. Any questions, observations? Happy to approve the recommendations? Yep. Thanks for all that work that's gone into that report. Thank you.
Sandy could have just stayed up.
Okay, thanks, Chair. Yeah, I will appreciate the time and I will try and be brief, but obviously happy to take any questions along and respond to questions alongside colleagues. This is a mid-year performance report. We do these, not surprisingly, twice a year in a full report in June, and this is the mid-year report in February. It's also worth bearing in mind, alongside our performance reports that you see at this committee, we do publish an annual performance report that is published under the approved, well, through the approval of our publishing of that through the Chief Officer. We do that at the end of July every year. This report specifically focuses on national indicators. As is evident from the report we've just seen, we are trying to capture all our local indicators in our strategic planning updates that are coming through regularly to the IJB. And as section 5.2 of this report notes, A number of the indicators only come through every 2 years, and a number of the indicators, although we've captured them here, a number of the qualitative indicators have already been the subject of an IGB report during 2024, report 3224. So we have seen a lot of these qualitative indicators already. And that means the key quantitative indicators that are new in terms of this mid-year update are really the ones that are summarised at 5.4, but are also set out on page 144 of the report. And these are listed in a tabular format and also shown in a graphical format. I'm not going to go through them in detail, but it is worth mentioning that generally the Angus performance still compares relatively well with the Scottish averages. That is the general position. And at that, Chair, and partly in the context of brevity, I'm happy to take any questions.
Thanks, Andy. Any questions, observations? Lewis?
Yeah. I guess how much, pressure are on staff teams across the kind of partnership and health and social care portfolio to, have their recording, their stats, their performances looking good, to keep looking like we're in line with kind of national average? I mean, there's a lot of pressure there, because we obviously want to be looking like we're doing well, but at the same time, how do you get that right and that balance with actually people being able to feel confident that they're perhaps not doing as well because of the funding issues and the resourcing issues that we have? Hope that makes sense. I guess just the culture around that is that, of course, we want Angus to be the best performing. However, in reality, if there's a lot of pressure on staff teams to have to demonstrate and show that and report that, but we're doing less with more, as I've said before. Does that make sense?
It does make sense, and I guess I'm going to go back to something that Alison mentioned before around how we triangulate what we're doing, the data and the information, but also that kind of wider quality management. So I guess we won't go chasing a target. We will continue to try and do the best that we can do. And if we don't achieve a target, then it's a learning point for us in terms of why are we not, what are the gaps, how can we do something differently, how can we improve it. So I personally wouldn't say that there's pressure on teams to go out and in terms of the targets. What we want to do is provide good quality care to all of the people that we provide care for. And I think that, Alison, you might want to come in on this, how we pull that together through CCPG, and for individuals that are around NHS Tayside at the moment. Nikki talks a lot around the quadruple aim, so it isn't always just about the performance, it's not always just about the money. It's the money, it's the people, it's the workforce, it's the quality, it's everything that we do, and we have to try and balance that off. But I think we have to accept that we're not going to be perfect at everything, and we identify that, we pick it up, and we learn from that.
Yeah, can I just maybe build on that one? And a lot of the indicators that we're describing in this report here, these are kind of big picture indicators. We have got lots of local indicators, we also have operational indicators, but these big picture indicators like the number of emergency bed day rate, there's a lot of factors that contribute to that. And I suppose this is probably really more a judgment, or I shouldn't have said the word judgment, but it's more a reflection of our the way we are as a whole partnership and the decisions that we've made as a whole partnership, as well as obviously the way we manage our service delivery. So this is big picture metrics here.
Thank you. I would say that the emergency admissions and the emergency bed days have not changed hugely. They're quite stable. The big change we saw was when we moved to enhanced community support years ago, 10 years ago, and we have maintained that model. And while managers or myself and Scott will be looking at the data when it comes out regularly, and we discuss it through EMT, there is no pressure at an individual level in terms of the admitting doctor, and it usually is GPs or ANPs more and more. We don't talk about the data in terms of their individual admission rates or anything like that. where we're looking at the data is admission rates, bed days, and then we're looking at team level, locality level, and we can see patterns. And then we work with maybe a team's not functioning so well, they've maybe got a bit of a deficit social work input, and that you can see that reflected. We have the theory, we put the change in, and we monitor it with a sort of quality management approach. So certainly at individual decisions to admit to hospital, we've got improved processes, you've got consultant to professional advice, so GPs can phone and get their acute frailty consultant, so the MFE doctor for their locality will answer the phone. If not, it'll be one of the team, and you get that advice. And so we're making improvements like that and monitoring the data the whole time. And I think that has been reflected in our approach for urgent care. More generally, it has been around that quality improvement approach. Test the change, monitor the data, and continuous evaluation. But certainly at individual teams, I'm not aware of any pressure being put on them.
Okay, thanks for that. Julie?
Yeah, thank you, Chair. Kind of linked in with what Alison has just said. The difference from 5-6 years ago to now is obviously because of COVID, which is huge. And I'm sure we'll get to a point where the indicators are no longer relevant because we're doing things so differently. And that is also being monitored because we need to be measuring the right things. And I guess the investment that we've made in prevention and early intervention is a really hard one to quantify in terms of positive outcomes or impacts on the system. But that, I think, is where the nuggets really lie, how people's lives are being improved and how system pressures are being eased by doing things differently. And I can see Scott's face there, and I'm just hoping that he comes in at some point. So, because it's good to get that clinical perspective as well through the likes of Alison and Scott, just how different care is and prevention and early intervention is and what a difference that is making. And going back to the discussion around the budget, we've held on to some reserves to allow us to do an additional investment in that work, and there will be further opportunities to look at different funding pots to enhance that. So it's not an entire deficit model in terms of the budget. It's about where we need to spend that money. And I feel more confident now than I ever have that all bits of the system are looking at that collectively. I've really not been in this place to the same extent before. So I hope people take a bit of confidence from that. But I know there's a huge amount of work goes into these performance reports, but at one point, and fairly soon probably, we'll have to recognise it's comparing apples and oranges because the system is so different. Thanks.
Yeah, no, I think you make an excellent point there, and certainly when we look at the Sandy's reports earlier on the finances, then prevention and intervention is clearly something we need to look at. Scott, you've got your hand up.
Yeah, thank you. Just to show Councillor Bell that I was diligently listening, but absolutely, thank you so much for inviting me in, Julie. It's a pleasure. I completely echo the points made by my colleagues. We know that there's limited evidence for the things that really matter. And so things like continuity, things like the ability to see the same person, things like that early intervention. With our older failure population, we know it's going to be more complicated. We know things are going to be more difficult. We know there's going to be more polypharmacy. There are more medicines out there that we will talk about later on. But as such, we need to focus our efforts in that preventive area, because as much as it means that you have to dedicate the biggest volume of intervention to reduce the end points, it is by far the more cost-effective thing to do than to be fixing it further downstream. So even in our urgent care ecosystem that we developed a couple of years ago, our very first step in that is the prevention of urgent care in the first place. So absolutely, those future care plans, those preventative things, our work with the respiratory stuff for making sure that people get their pulmonary rehab and things. So they're all upstream is definitely where we make the investment. And certainly we've got a good work stream there supported by Sally and the team, and Blair, of course, as well, trying to make sure that we are in that arena. Alison is very much up the middle of that, as well as we all are, to be honest, because if we don't all get in there, we're going to reap the downsides of not investing in that area. So yeah, very supportive of that.
Thanks, Scott. Any other? Yes, David.
Thank you. Looking at the qualitative indicators, I mean, I have some concern about a number of them moving in the wrong direction. But my question really is, do we have a longer timeline that we can look at, given that this starts in 2019-20, when strange things happened, a lot of numbers in that 12 months. Are we able to look back before that and have a longer timeline?
Yeah. Thanks, Dave. I think in here, somewhere in the report, but I can't explore it quick enough, there is an issue about the longevity of some of the indicators, and some of the metrics have changed over the course of actually it's maybe section 4.2 of this report. Anyway, some of the metrics have changed. Yeah, there has. Yes, well, I can't quite recall which indicators it applies to, but there has been some methodology changes. If though there is older and more qualitative indicators that go further back, I'll check back with Paul Feltham, who's brought this report together, and see if we can maybe just share that on a one-off basis with everybody. It does make the reports quite big, but I'll see if we can do that on a one-off basis if it exists for probably 2000, I don't know, well, 2 years probably before that. Okay.
Thanks. Any other questions, comments? Are we happy to approve the recommendations as outlined in the report? Yep. Excellent. Thank you. That takes us on to item 13, minor injury and illness service.
Okay, thank you, Chair, and good afternoon, everybody. So this paper on the MIU sets out a strategic vision for minor injury and illness provision in Angus. Just to give some reassurance, picking up on some of the conversations earlier, to get to this point, there has been a good deal of consultation and engagement, primarily with stakeholders and a lot with our staff to provide insights around the service, etc. The purpose of the paper really is to set that out and to ask for the support and endorsement of the IJB to continue with this work with a view to bringing back a more detailed proposal in the June session, and really permission to go ahead with much more of the engagement and, crucially, the public engagement side of things prior to bringing a proposal back. And,
Thank you. I have to say I really liked Appendix 1 there on a page, and actually what I really liked as well was what success looks like. And I think that's really quite a powerful kind of appendix. So many thanks for pulling all of that together. It's a really good report. Yes, great.
Thanks for that report. Going on to next steps, public and staff engagement. I know that it's very difficult to involve the public and the services at the inception of a project, because a lot of it is quite clinical and difficult to, it would take a long time to explain it to the public. But my question is, when this goes ahead, how much capability will the public have to change the direction of some of these things, or is it just a list of services? This is what we're going to do. Do you like it or do you not like it? Or is it going to be, can they redesign or co-design some of it? That's...
So will I bring Scott in at this point? Are you answering the question there, Scott, or would you like me to do that?
I'm happy to. I'm happy to pick up, Lisa, if that were. That's an extremely important point for us. The average person might use minor injury care once every 5 years or so, if that. And so they're trying to ask the general public, can you give us an opinion on something that you might use once every 5 years? And that literally might be for 10 minutes or something, is really difficult. I completely agree. And trying to ask them to even hypothesize, well, what would you like for care? Invariably, somebody's going to say, well, I want that right next to me. Even if that's delivering a baby or thrombolysis for a stroke, you're going to want it as close as you can get it to. What we are going to be doing is asking for ideas, asking for, have you experienced our service, but also doing probably more focus work as well about asking people who are actively having care at the time, asking them about their journey to describe it. It's called a care experience improvement model. We've used it before, and it helps us get really detailed feedback about our service and how it's working, and also gives us ideas about how it could work even better. So people might describe a process to us that lets us work out how we do that. But no, I wouldn't. I would challenge to say that it's going to be, I think there might have been an inference there that is it just going to be, this is our presented model. Lisa, I don't have a model. I don't think you have a model yet either. And we don't have an answer about what we will look like. Where our resources will allow us, we want to deliver care as close to the person as we can, but also for it to be efficient and effective, because there's no point in having resources somewhere that's only going to see 1 or 2 people a day. But equally, we need to make sure that we listen to our public and say, well, have you experienced our service? What was it like? We have already been doing that, and we've intimated some of that in our report, where we've looked at processes, for example, when people are accessing GP care and happen to have a minor injury. We've now got a really efficient process where they're moved directly across to the minor injury unit and you're appointed directly from there. There's no more, there's 2 or 3 extra steps that used to be in that process. We've got rid of them because we've got feedback from our public and from our staff saying there was a better model to do. So no, there isn't anything as yet set out. We're seeking IGB's consent to say we've been testing some things. It seems to be working. We'd like to continue that, please, with your consent, to say we want to continue to test what things look like to make sure that they're the most effective things for Angus.
Thanks, Scott. Julie?
Thank you. Going back to an earlier discussion around out of hours, I know out of hours is described in here as a stakeholder, but it seems there's a huge overlap here in terms of what's provided where and when. And will that be integrated at some point? Thanks.
Yeah, happy to pick that one up, Julie. So members may recall over a year ago now we brought an ecosystem around the urgent and unscheduled care, and that still describes that overall kind of system for the provision of urgent and unscheduled care within a community setting. So out of hours absolutely are a stakeholder as a service within their own right, but this is going to be all brought into the wider kind of work around how we navigate care for minor illness and injury over a 24/7 period.
Yes, Martin.
Thank you very much for that. I noticed on your vision that's about providing for adults or children any time of the day or night. So how's that going to be achieved?
Scott, do you want to come in? Sorry.
Yeah, that's it. Well, at any time of day or night, we can provide minor injury care, but it's whether you need it at 2 o'clock in the morning or whether it can wait until a more appropriate service. So, for example, it might be that the best person to see you for your small abrasion to your eye is probably an optometrist, and they open at 9 o'clock and they're super good at doing these kind of things, and that's who's possibly the person that should see it. Likewise, however, if you've got your ankle broken and it's sitting off at 90 degrees, there's an A&E that's really capable of looking after that thing. So we deliver care where resources are appropriate for the NHS to make that investment. But yeah, that is our vision. We still stands, I think, 24/7, closest to the patient within the resources that we have available to deliver it. And it's that important last little bit that helps just give us making sure that we're doing the right thing with the public purse. Because yeah, absolutely, everybody wants it at their doorstep 24/7. That's also needs to be practical within the other resources that we have. But I promise that we will, if it's needed 24/7, things are there 24/7.
Thanks, Scott. Anything there, Ron, and then Lewis.
Did go on, sorry, it's switched off. Yeah, I guess the one concern or feedback that sometimes comes through to me is families individuals who don't have perhaps transport. So sometimes that can be an issue, especially if they are having to travel Arbroath to Ninewells, for example, or perhaps rurally. And I know that there's a challenge there as to how we address it, and resources are limited, but yeah, that is something that comes through that I guess my concern is that the knock-on impact that has if they don't get treated at the right time.
Yep, Scott.
Okay, yeah, thanks very much. And it's something that comes up in, of course, in our quality impact assessments that we do surrounding these kind of changes. We're acutely mindful that we're not in charge of the transport network, but that we do live in a rural population. We need to then consider what's the balance of having a service somewhere because someone at some point might not have transport versus what's the reality of the common volume that would merit something being somewhere. We're also got an issue. So, for example, if you can get yourself to Arbroath somehow on, say by an ambulance. So, say we said, okay, fine, an ambulance will be provided because we'll take you to Arbroath because that's the more local thing to do. If you can't get out of Arbroath, what are you going to be doing when they shut? Because we don't have ambulances that take people home from Arbroath at 5 o'clock at night. That's not how the ambulance service works, and they're not resourced to do so. So yeah, we do make use of a breadth of different transport options. We don't have possibly the kind of volunteer network that we might do, but we have seen that from VAA in the past, for example, where we've been able to provide some support to that. But if needs be, that we do have a kind of Alamo point of, well, there are no other options. No less often, I have to say, I would challenge some of the things that I've raised in the past where people have said they don't have transport, but the person can't walk. Well, I'm sorry, but if you can't walk, you're not staying at home because you're not going to be able to get around your house. You're not going to be able to get to the bathroom safely. And often, actually, the more safest place for a person is to go to hospital to get an ability, to get, for example, plaster casts put on, to get an assessment made of whether they're safe to be at home, and then they can go home once we know that they're safe to do so. We shouldn't be trying to do that somewhere which is not kitted out to look at that. But it is something I'm acutely mindful of and definitely will be part of our EQIA process. But yeah, there's limits within that, you'll appreciate as well. But yeah, message is loud and clear, I promise.
Thanks, Scott. Yes, Ron.
Yeah, thanks. Just for me, I've been involved in initial discussions from a staff side point of view in some of the proposals, but I think the consultation part's going to be key. I still do have some concerns around about what it means for a workforce, because you may have workforce that work in X, but there might be an expectation that a workforce has to work in Y. And it might not just be as easy as doing that. So I think we're at a start of a wee journey, if you like. But I think the consultation part is key with the general public and the impact that can have. Thanks.
Yes, so thank you for that, Ron. And I think one of the things that I would really like to emphasise is that so far the work that we have been doing has really centred around our staff, and we've done a lot of consultation engagement, really taking on board staff ideas, and staff do have lots of good ideas around how things should be delivered, and most of them are local to Angus as well, so they care not just from a work perspective but as members of the community. So I'm really assured that we've set the tone right with this, We've been working from day one with staff and staff side. And another point I would just like to bring in to provide a wee bit perhaps more further assurance is that we're very heavily engaged with Health Improvement Scotland around this work and the working involving people work as well. So Sally and the team have had lots of discussions and meetings. So we've really been doing that in partnership as well to make sure that for this really important piece of work that we really do cover all bases and really try and get as much community and public engagement as possible. Okay.
Thank you. Okay, are we happy to approve the recommendations as outlined in the report? Excellent. Sorry, microphone was off. It takes us on to item 14, homeless supported accommodation review.
Thank you, Chair. Okay, so we've touched on some aspects of this through previous discussions, but I'll just give a little bit of narrative to the report. So we know that suitable and stable accommodation is an absolute bedrock in improving health and wellbeing outcomes in Angus, and it also has a preventative and enabling role too for people to live longer and healthier lives. And as we've discussed earlier, we know the link to public health and just a clear link to basic human needs and human rights to have somewhere safe to live. The Angus Council Rapid Rehousing Transition Plan, which is 23 to 24, highlighted those who experience homelessness in Angus should reach a settled housing option quickly, and the report highlighted key objectives from this plan. In Angus, we know that we do have some challenges in association with accommodation, and we do have a small number of individuals who are currently residing in B&Bs for periods longer than they should. We're also noting an increase in homeless applications and interventions from the Partnership's Homeless Prevention and Support Team. We also acknowledge, as we touched on earlier, that Angus Council has set up a new housing committee where actions relating to housing stock will no doubt be taken. So it is a challenging picture in a lot of respects. An action within the Rapid Rehousing Transition Plan was to review the supported homeless accommodation provision in Angus. As mentioned earlier, because we have the Homeless Prevention and Support Service within the Partnership, this review was taken forward by the Partnership and it commenced in February last year. The review ascertained the current and projected future demand alongside understanding the current models of care that exist and what should exist in the future. At that point, though, unfortunately, due to changes in staffing, the review was paused in September last year, but we have identified further staff and resource to continue this review, and it is now recommenced. So the review will conclude, and we will bring a report back to IJB in August this year, bringing proposals around the adequacy of the existing provision, what future models for delivery could or should look like, also ensuring that the principles of the rapid rehousing are applied across all homeless supported accommodation within the Partnership, and also maintaining a strong collaborative approach with Angus Council and the newly formed Housing Committee, as there's an absolute clear link here between supported accommodation and homelessness and the link to available tenancies for individuals to be supported onto. So you'll note within the report 3 recommendations for members to consider. We've also got Karen and Morgan here who, alongside myself, are happy to answer any questions that you may have. Thank you.
Thank you. Any questions? Lewis?
Thank you. I just wondered if these services are starting to see the impact of the housing crisis and the pressures in the system and other housing stock. Is that spilling over into supported living accommodation?
I'll come in on that. Karen, feel free to come in after me. I'm seeing lots of nods at the back of the room, Lois. Yes, I think absolutely we're seeing the impact on that. The fact that we do have a number of individuals in B&B accommodation, often for periods longer than they should, is a telltale sign of that. We know the current housing crisis that's been well documented within the press, which is a local and a national issue, but I think from our conversations, Karen, I know that the Homeless Support Service is receiving a huge increase in the number of referrals, often quite complex individuals with multiple needs. I think what we've highlighted earlier through a number of discussions today have been that clear link between poorer health needs and often poor accommodation or unstable accommodation. So often seeing layers of complex needs associated with that. So not a kind of one-size-fits-all approach, often quite intensive support, longitude in terms of relational interventions as well. So a number of challenges.
Thanks for that. Julie?
Yeah, thank you. I was particularly drawn to the paragraph around Cliffview Court and Chapel Bond because I know the level of need within the tenants there has increased over years, and it just made me think about the overall staffing complement and skill mix that are contained within all of this. So it would be really helpful to see that in detail. And around potentially any gaps, because if there's something that we need to change to, it would be good to make the most of the staffing resource that we've got and the skills that have been built up over the years, but also any gaps that allow some innovation or transformation that would be creatively but safely supporting people as we move perhaps to a slightly different model. Thanks.
Yeah, thanks, Julie. The staffing model within our own resources, they are a skilled staff group. We have senior social care officers involved as well. A number of the individuals who live within those resources are also open to often community mental health teams, so are having support from a number of different angles in terms of the overall care that they receive. But you're absolutely right, this is something that we'll look at through the review, so the staffing mix will be a part of that, as well as looking at the plans for those individuals. It's temporary accommodation in nature, and it's ensuring that we have that supported throughput where we can, that's timed well, and that individuals are supported into tenancies beyond what would be classed as, that temporary supported accommodation. Thank you.
Thanks, John. Any further? Nope. Are we happy to approve the recommendations as outlined in the report? Yeah. Thank you. Item 15, primary care prescribing update. Yourself, Scott.
It is, yeah. Thank you so much, Chair. So I'm grateful for the IGB to approve this. You'll note the recommendations are fourfold. First of all, to scrutinise the paper, which will be in a familiar format to you, to acknowledge the increased prescribing costs, and you'll note the finance section there with the quite difficult prescribing increased spend that we have faced, and that's almost entirely driven by the increase in costs that are applied against them, for which we don't have control. Approve the alignment of reporting. So this is an important one. This is a subtle, slight change. The scrutiny and the degree to which we work to improve the quality of our prescribing and to review it will not change. But what we are proposing today is, should we be aligning this within the work stream that it sits, which is within the preventive proactive care priority. So rather than it coming to IGB directly, should we be aligning it closer? And I'll maybe bring Jill in on that point as well, because we do have good structures to assure ourselves. We have a group and a governance structure for prescribing. So it's to see whether IGB would agree to align it would be a better way to do so, and also endorse the reasonable level of assurance that we've applied to our prescribing, and that's looking at the prescribing quality. Remember, I can't help some of the bits around here with regards to the price increases. So you'll see in the background, we summarise that. The current position, you'll see there, we've discovered recently why we have quite an erratic prescribing cost. You'll see there month to month, our costs vary massively. And that's just to do with partly to do with the way that repeat prescribing is set up in Angus, and it's unique to the practices that are got high levels of prescribing of serial prescribing, and that drives a massive month-to-month variation, which is not reflected in actual prescribed medicines, but it does make interpretation of the graph quite hard to align. And so we're going to be moving to a three-monthly graph, which makes it evens the levels out. Environmental, I think Councillor Bell, on your previous tenure, you mentioned how important that was, and it is important to us as well. And we're going to be doing much more around CO2 inhalers, for example, because there's some prescribing changes which are likely to make that a little bit easier. So that's reported within there. And we have a new dashboard format as well for our practices to start to see some of their information much clearer, so that they can start to see that things are an improvement. And there's some examples in there that we've put in there, some of our priority areas, looking at, for example, those living in care homes, making sure they get medication reviews, and the average number of repeat items per care home resident. And you can see there, with medication reviews going as they are, we're managing to reduce the average number of medicines that people are taking cost in a care home. We're also looking at the number of repeat items there, and also the percentage of serial prescribing. Serial prescribing gives us opportunities to review medicines more proactively. So there's a few different things, and there's some details about some of the initiatives that we're doing with regards to medication, things that are within our gift, but there's in the financial implications section 7, there are some things that are not. But we are working very hard. We are very aware of this. I see Mr. Coulson there. There's our Director of Pharmacy, working very closely with our full breadth of our teams across primary care, including our GP pharmacy services to support. And I just want to Jill, I don't know if you want to come in on that recommendation 3 there with regards to the reporting of it, or to refine any of my wording there to make sure I've not been clumsy unintentionally. So yeah, other than that, thank you very much for.
Thanks, Scott. I think for members' awareness, priority 1, prevention proactive care, has a sub-priority around optimising medicines, which is in line with the NHS Tayside programme of work as well. So the proposal is that we've already got a optimising medicines element, but we're looking to bring some more of the kind of efforts, primary care prescribing, into that work plan and combine the two together.
Thanks, Scott and Jill. Chris.
Yeah, thanks, Chair. I just really wanted to ask a question about the delivery of the prescribing work plan as it's been devolved to GP and primary pharmacy teams. What support do we give the individual GP practices and teams to actually help them deliver that?
Yeah, so there's quite a bit of different parts to that. So some of it might be that we have to provide the information to them. We have to make sure the information is clear. We have to give them sometimes prompts and support so that things are naturally done in an easy way. So, for example, if I spotted it the other day, we were prescribing a form of a blood pressure medicine which was 4 times the price of the other forms of the medicine, and we'll put a little prompt in so that if anybody tries to prescribe it, it'll prompt them. So we have to also do improvement by design. It's not just improvement by lots of extra work. There are some specific things that we have to do for more technical or specific things. We have a really mature infrastructure with regards to improving the safety of prescribing and how we prescribe, which is very, very sophisticated, and because prescribing is very, very complicated. But for bespoke things, we might well have to support with resources around to do a specific switch. But I have to say, those are far fewer and far between. 10 years ago, when I was first coming to the IGB, I could have rattled off 10 or 20 technical switches or switches that I could put money behind and say, look, I'll pay for a bit of time to move people from X to Y. Those low-hanging fruits are so few and far between now that we are very much more looking towards improving the quality of prescribing, and that requires far more sophisticated system improvements, including, for example, I see Dr. Schofield on the call as well, working closely with our secondary care colleagues about what do we choose to prescribe and when, and how do we make sure it's within pathways of care which not only use medicines but also make sure that we're not negating the non-medicines options as well.
Thanks. Any other questions? Nope. Happy to approve the recommendation. Oh, sorry, Alison.
So very quickly, the logic for moving it in within prevention and proactive care is because we should be applying the same scrutiny to medicines as the non-medicines alternatives, and we don't. We prescribe a lot. We put a lot of emphasis on pills and getting the right pills in the right place, but we don't necessarily put as much attention onto getting the right other interventions, such as your physiotherapy interventions, your better balance classes, pulmonary rehab, all of the sort of wider things. And I think that's my real drive for having within prevention and proactive care. We look at pathways of care, make sure people have access to the right thing, the thing that's going to help them the most, and not just always rely on medicines. And that's the ethos behind it.
So everybody, Martin.
Can I ask how the figure of 56 weeks for review is taken? Could that be shortened, or is it
So
arrived at a figure?
Okay, so 56 weeks is picked because if it's your birthday on the 1st of August and your review is prompted around your birthday on the 1st of August the next year, you might not get an appointment on the 1st of August, or you might be away on holiday yourself. So 56 weeks has always been picked as a kind of slight overlap, allowing 4 weeks grace period for anything that's going to occur annually. It's a convenient way to look back. So if I was looking at somebody that had a medication review, if they are always done, say for the big care homes, they might be done annually in the first week of November. Chris, I think you've got a sneeze there, my friend. I'll mute you. Where are you? Oh, you've muted yourself. There you go. Bless you. So yeah, 56 weeks is just taken so that we don't miss that on an annual process that somebody is just outside that 56 weeks. That's the only reason that it's picked for that duration. Okay.
Is there any leeway then digitally that we could actually start to review on a more up-to-date process? Because we should have the capability to be able to review being realistic, every 2 or 3 months.
Yeah, I mean, I suspect you maybe slightly underestimate the volume of medicines which are prescribed. In my own practice, I would be talking about 10,000 items a month. I wish I could review every 2 to 3 months. The resources wouldn't allow it, and it's not necessary. If we're clinically needed, absolutely, we might be reviewing things every month, every few weeks, when we're increasing medicines or when somebody's unwell or unstable. But if you're on thyroxine and you are on that every year, I will, and you've been on for 5 years, once a year is more than sufficient to make sure that your blood tests are up to date and that you're content that you're still getting it regularly. So it's tailored to the individual. Annual for most things is the safe convention, but it's certainly less for some things. It's certainly never usually more than that, I have to say. Annual is the kind of usual maximum, but hopefully that explains. But yeah, the volumes are just too big to do it more frequently, but I wish we had more resources, as the First Minister might have mentioned the other day, to do it even more often. But unfortunately, I can't. But not even it wasn't even within my gift to persuade.
Okay, we happy to approve the recommendations as outlined in the report? Yep, brilliant, thank you.
Thank you.
And that takes us on to item 16, Angus Suicide Prevention Action Plan.
Thank you and good afternoon, everybody. I'm pleased to bring this report this afternoon with an update on Year 1's progress to deliver Angus Suicide Prevention Action Plan 2023 to 2026. You will see that it's been a positive and productive year, and I want to highlight on page 172 how well we are doing against our national outcomes. You may also be aware of a strong social media presence around the Are You OK campaign and the development of a suicide prevention page on our website, and the number of hits and activity around that is outlined in the report. On page 173, we also highlight updates on the actions being progressed across our integrated mental health services, which contribute to this suicide prevention plan, including our work around our enhanced community support hubs and our community wellbeing centre, which is now known as the Beacon. I'm pleased to refer you to our recommendations, and in particular that we are seeking to offer a significant level of assurance of the work that we are doing on this agenda. I'm delighted that Gail Forrest, Lead Officer, is online to take any questions. I want to thank Gail and her team for all the work they have done on this area of work. Thank you.
Thank you. Yes, Julie.
Thank you, Eunice, and Gail, thank you. I've been very close to a lot of this work, so well done on the achievements to date. One of the issues that I've been aware of early doors was around data collection from other agencies, and I just wondered if you feel we've got to the right place with that yet. I know there have been improvements because it's disparate services, different IT systems, what have you. Do you feel that we have made enough progress in that area, or is there more yet to do? Thanks.
Thanks, Councillor Bell. I think there is more that we can still do. I think we are restricted sometimes in terms of data protection and information sharing agreements. But what I can give reassurance at the moment is that we have our information sharing agreements with the police and with health, and that allows us to have the relevant information that we need right now to make the improvements. And then with the contracts that we have in terms of mental health, we're able to get the information from them as well. There's always more that we could be doing, but nationally this is a struggle, as you know, and I would probably say that Angus are ahead of the game because not every area has an information sharing protocol, even with the police, to get the information around deaths by suicide. One of the areas we do need to work on is attempts, and that is really, really difficult because of data protection, because the person is obviously still alive. But that is something that we're working on with our social work colleagues.
Super, thank you. That's helpful. I'll try and pick up the national data sharing issue.
Yeah, thank you for this report. I just wondered if there could be a brief update in terms of the Beacon project, but also, I guess, just quite timely, given where it's at, the target date for that work commencing, which is really positive. But because of the budget position and the potential in terms of employment costs and national insurance, is there any risks to the project, or will that continue on in the same vein?
Gail, are you happy to answer that?
Yeah, no worries. Thanks, Councillor Speed. No worries or risks at the moment. The Beacon work is being taken forward by a project board, which has its risk log and mitigating any of the risks that come up. The support service contract starts on the 1st of April. The refurb contract started on Monday. The refurb will be completed by the end of April, and the support service will have a soft launch from the 1st of April, given that we won't actually be in the physical building. But again, the project board is managing that and mitigating any of the issues that come from that. In terms of national insurance specifically, what you were saying there, Lois, obviously that's an issue right across the board, but that is one that we are obviously working with Hillcrest with. And at the moment, there's no significant risks. In terms of the finance, we've had to do a lot of work internally looking at the mental health contract, and we are confident that we have obviously all the funding that we need to move forward with the Beacon for the next 3 years.
Thank you. Yes.
Thank you. Thanks, Gail. It's really helpful to see this here. So I just wondered about any particular targeted approaches we might be taking to ensure engagement and information around particularly young people, and also gender-specific approaches, so particular risks around men, but also particular needs of women. So I wonder in terms of the year 1 work, but also moving into year 2, what that might look like.
Thanks, Kirsty. Yeah, there's nationally, children and young people are a focus for the year 2. So our local implementation is following that of the national, and we are linking with our colleagues within social work and within education who sit on the suicide prevention work stream to determine actually what that will look like in year 2. And that's starting with a survey, Kirsty, of children and young people of what is currently available and what the need is. And then that will inform our work going forward. In terms of gender specific, we are working with various partners on how we take that forward, but also taking a lead from our national colleagues on that one. So it's definitely in there, and it's to be determined actually what the specific actions are in terms of year 2. So I think that's young people and gender. In terms of males, we always know that males are twice as likely to die by suicide than females. So that is a big push in terms of the work that we do. So we've got SAMH changing rooms happening in the area. We work closely with Andy's Man's Club, and they sit on the work stream as well. And then the general population, as Eunice mentioned in our opening remarks, is around the Are You OK? And we've got specific targeted areas on the rollout of the Are You OK? To cover all of those areas.
Yeah, very question. Does that also include veterans as well? It does.
They are on the list as well. Yes.
Great.
Okay, anything else? No, we're happy to approve the recommendations as outlined in the report. Yep, excellent, thank you. Before we come on to the date of the next meeting, Susie Brown, Nurse Director, I believe is her last meeting. I hope that's got nothing to do with me becoming the chair, but on behalf of the committee, wish you all the best, and thank you for all your hard work.
Thank you, Chair. And just to add, nothing to do with you being the chair at all. Thank you very much.
Thank you. Okay, the date of the next meeting is Wednesday, the 30th of April, 2025. And obviously, we've talked about the potential of a special meeting before the end of March. And obviously, once we have further clarification, we'll get something in the diaries as quick as to kind of put that. So thank everyone for your attendance, and I'll see you all in the 30th of April. Actually, I'm actually on holiday on the 30th of April.
John, can you stop the live stream, please?